Good evening. We want to welcome all of you to the Georgia State Medical Association meeting. We're scheduled to begin at 6 p.m. and we will begin our program in the next minute. We're just waiting for some additional people to set up their audio to join us, but we will be starting shortly. While we're waiting for those individuals, we'll just go over some house rules. Please ensure that your phones and laptops sounds are switched off. If you haven't already changed your name in your Zoom name, please go ahead and do so to help us in identifying during the Q&A sessions. And also, as we go through the program, feel free to put questions into the chat box, and we will address those questions on a panel and speaker by speaker basis. Okay. During the call, if there are any problems that you have with connecting, please send a chat to one of the moderators or hosts, and we will work on trying to get you into the meeting. Okay. The partner that we have for our CME is the Morehouse School of Medicine. And we have reviewed the full disclosures of all the speakers and panelists for the program, and we did not find any real or apparent conflicts of interest. We will be offering CME credits, and you'll find the speaker disclosures on the GSMA website at the end of this meeting, and all speakers will, of course, make a disclosure prior to their presentations. We have been accredited for 7.75 hours for the entire program, and it will be 2 credit hours for this evening and another 5.75 for tomorrow's program. At the end of the program, you will have a display of a specific QR code, and you will use that link with a code to claim your CME credit. And CME credit is available to all registered and dues paid GSMA members. There's a formula to success for this particular program. We want you to listen, to learn, to contribute, ask questions, and also to become part of the change you want to see happen, both for Georgia and for the US. That can happen by joining the Georgia State Medical Association and the National Medical Association. With that, I'm going to turn the program over to our esteemed president of the Georgia State Medical Association, the one and only Dr. Erica Russell Petty from Savannah, Georgia. Dr. Petty, take it over.
Good evening, good evening. I'm so glad that everybody is here. We have been working hard. Of course, we wanted to have a meeting where everybody could be in person, and you know, all things considered, we definitely felt like this was the best thing for us to do this year. So I'm so glad that so many of you are taking this time out to be with us this evening. And definitely next year, we look forward to being able to be in person. Like Dr. Price said, I'm Dr. Erica Russell Petty. I am the president for the Georgia State Medical Association. I became president last year, and my tenure will end next year. I want to welcome you to our 128th annual and first virtual convention of the Georgia State Medical Association. I would say, I think Dr. Price might have mentioned that you have your log on for today, and then you'll use that same log on again tomorrow morning to again join us. For tonight, our opening event and award ceremony, that will be for tonight, and then tomorrow will be our scientific program. So with no further ado at the moment, I'm looking to see, hopefully Dr. Walden is on. We were going to have my Pastor Rouche, but he will not be able to be on this evening. So Dr. Linda Walden will be bringing our invocation.
And Dr. Walden is unable to join. Would someone else like to?
Is Dr. Shelby on? He's the other person that, is he on?
He is not.
Okay. Then I will pray. I'm the chaplain. I will pray. Thank you, Lord. Thank you, Jesus. Lord God, I just thank you, Lord God, for this time, Lord God. I thank you, Lord, for just bringing us through another year, Lord God. We thank you, Lord God, for our health, Lord. We thank you for allowing us to help so many others throughout the year, Lord God. And we just pray, Lord God, that even as we do the things that we do, that you continue to strengthen us, keep our families, so that we can continue to do those things that you have planned for us. We thank you for the Georgia State Medical Association. We just ask that you continue to lead and guide us to always be in the midst of everything that we do. We ask these things in your name that we pray. Amen. Thank you. So I did want to take a moment to also, again, thank God, and I wanted to thank my own family. Today is our 27th anniversary of me and my husband. So I just wanted to take a moment to recognize that before I got started and before the night got away from me, and to thank my family and my children.
Happy anniversary.
Thank you. Thank you. So
I'm on.
You're on, yes.
With all that's going on with COVID, we need another prayer. So we do.
Yes, so we're going to let you go right ahead, Dr. Walden. Thank you for joining.
Okay, let us pray. Most gracious Heavenly Father, we thank you for allowing us to convene this evening for our 128th Georgia State Medical Association Annual Convention and Scientific Assembly. Thank you for blessing us individually and collectively. Thank you for all our heroes and sheroes this evening who have been drum majors for medicine and making sure we have quality health care. And in spite of all that's happened in the last year, we are still here. We ask a special blessing for Dr. Warren Hutchins and family, that you will comfort, strengthen, and bless them in the loss of his brother, Dr. William Hutchins II. Thank you, Lord, for ordering our steps, guiding and leading us in the direction you would have us to go. Strengthen and inspire us with your wisdom and understanding and love as we make a difference to improve the quality of health for our patients and bring about health equity. For we are nothing without you. And may we continue to be mentors for our youth to increase the pipeline of African-American physicians in this country. May your light enfold us, your spirit guide us, and your grace abound in us. This we pray in Jesus' name. Amen.
Amen.
Amen. Amen. Thank you so much, Dr. Walden. So, as many of you know, we are being joined this year by the members of the State Volunteer Medical Association of Tennessee. So at this time, we are honored to have the president, Dr. Cornelius Mance, who will give us greetings. Is Dr. Mance on?
Unmute.
Is Dr. Mance on? If not, we'll,
Dr. Lisa Perry-Jilks is available.
Right, yes. Sir. So what we'll do is we'll come back to Dr. Mance. So at this time, we're going to ask Dr. Lisa Perry-Jilks to come on. Dr. Jilks is the current president for the Medical Association of Georgia. And so we're going to have Dr. Perry-Jilks to give us greetings.
Hi, can you guys hear me?
Yes.
Okay, I want to say happy Juneteenth to all. And I want to count our blessings for us to be able to meet at this astounding event in this new and modern way. Unfortunately, I'm not so new and modern and I can't get in. But thank goodness for Kimberly's telephone. I would love all of the attendees here and thank everyone for being available for this meeting. It is amazing that we can carry on, but we've always risen above consternation. The Medical Association of Georgia, as you you may know is the Composite State Society for the American Medical Association. I'm the first African-American female president, and one of 3 women and one of 2 African-Americans. We are so happy to be able to be here and welcome everyone to this meeting. And I am honored to be invited to talk at the opening ceremony. I want to talk a little bit about my year so far. I had so many plans and wonderful issues that I wanted to look at, but as soon as I was installed, our CEO left for a better position. Now, the CEO was Don Palmisano, and he is an amazing CEO. He did very well for us, and he's moved on to be CEO of the National Association of Gastroenterologists. So my majority of my year has been finding a new CEO. So we have done that, and our new CEO is Jeremy Bonafino. But some things that we have accomplished, or I can say I have accomplished. At our last House of Delegates, we passed a resolution making a permanent seat available for alternate delegate from the Georgia, from GSMA. When I see Mag, and when I wanted to run for chair and president, I thought MAG should be inclusive of all. So we have to cover the entire state of all physicians. MAG should be the medical society that keeps us all together. I don't think any other organization should usurp the ones that we have, but we act better as a unit and we have more power. So I just want to make sure that everyone is at the table, and by doing that, I've made that sure. We also have new seats for AMPA, the American Nigerian Physician Association, GABI, the Georgia Association of Physicians of Indian Heritage, and the Pakistani physicians. Since my term, we have developed a diversity task force. And the mission of the task force states that MAG's diversity task force is enhance patient care and the health of the public by bringing awareness to and providing resources for health disparities, cultural competence, and social determinants of health. We have had the opportunity to do some things at our next House of Delegates in October in Jekyll Island. I please invite you all to come. Dr. Letitia Bilbrew will be addressing MAG's House of Delegates in the annual meeting to discuss health equity, disparities, and things that pertain to the mission's diversity statement. We really have come a long way, and I must give credit where it's due. I cut my teeth in SNMA. I trained at Howard University. I was the SNMA president there. And at my very first national SNMA meeting, to see how bold I was, I ran for president at my very first meeting. Well, clearly I didn't win, but it's all where we start from. And it's so wonderful to be able to have our students join the fold and keep them with us and train them as they come up in the importance of organized medicine. From that, I went to Los Angeles, where I trained in ENT at King Drew Medical Center. I really have seen my journey as one of a blessing. And I must say, I couldn't have done all of this if I hadn't started with SNMA, with NMA, and Georgia State. So I thank you for all you've done for me, and I would love to continue to have us work together and service our community. So thank you so much. I did get dressed up for you, but I guess you didn't get to see it. So thank you again, and I'm so glad to be able to address you.
Thank you so much. Thank you so much, Dr. Lisa Perry-Gibson. Yes, definitely. We are all together anyway, so we'll definitely all continue to work together so that we can bring about all, very, very common goals. So thank you so much, and we look forward to a even more productive year over the next year. So at this time, we're going to begin our plenary session. And I am going to ask Dr. Sanders. He will be our moderator for the beginning session. So at this time, Dr. Sanders, we will turn it over to you.
All right, good evening, everybody. Thank you very much. I'm very glad that everybody came to join us tonight. My job right now is to really introduce the program and then introduce the next two speakers. When we started to work on this program, we really wanted to try to generate a dialogue, even though virtual, to address some of the structural forces that lead to poor health outcomes. And our program kind of came together, and we're going to do some work around clinical trials and the importance of a diverse representation. We want to talk about the medical education pipeline, discrimination, and how we work over the next 5 years to assure that we have a strong workforce to follow us. And those two topics make up the first session of the plenary. And then we'll talk a little bit more tomorrow about diseases that disproportionately affect people of color. We're going to talk about environmental justice, climate, health equity, and climate change. And then to end that and try to bring it all together with some idea around the future of the practice of medicine. I think that one of the things that has come out of this pandemic, and I think we saw this with Juneteenth, is that many of the structural lines are softening. And I think we need to be prepared to help influence what happens before they begin to freeze again. So with that, I'd like to now move on to introduce our first two speakers. Our first speaker, and I'll introduce Dr. Wimberly after I introduce Dr. Trevor. Dr. Michelle Trevor comes to us from the US Food and Drug Administration. She's going to talk to us about advancing diverse inclusion in medical device studies, driving actionable solutions. Dr. Trevor, I'm going to turn the program over to you.
Hello, and thank you very much. I'm going to start sharing my screen. I think somebody has to stop sharing so I can share my screen. Perfect. All right. Well, thank you very much for that very kind introduction, Dr. Sanders, and thank you, Dr. Price, for inviting me, as well as Dr. Russell Petty for the kind invitation to the Georgia State Medical Association's convention. I'd want to speak to you a little bit about how we are working to advance diverse inclusion in medical device studies and how we're working and taking steps to drive actionable solutions. So first, to start, I work at the FDA, and the FDA is a big place. There are many different medical product centers. We regulate everything from food all the way to tobacco. But one of the three centers that work together primarily on the regulation of medical devices, medical drugs, as well as biologics. The importance of devices, is that our medical devices span everything from diagnostic devices, so things like the SARS-CoV-2 testing, all the tests that we run in the labs on our patients, glucose monitors, CT imaging, MRIs, you name it, we regulate it. We also regulate those implantable devices like pacemakers and intraocular lenses, as well as aesthetic devices such as dermal fillers and breast implants. So as you can see, there's a large spectrum of medical products, but it's important to always include the patient in that process. And we believe as a center and as an agency that patient input is very useful across the total product life cycle of a medical device. Patients help us understand what needs are not being met by the existing therapies. They let us know whether the device works well in their own hands, particularly those that are being used at home. Patients also can work with us as advisors in the design of a clinical trial. And in that process, they can help us create device studies that are patient-friendly, that are more likely to enroll the patients that are going to stay in the trial, as well as provide meaningful input in collecting the appropriate data throughout the duration of the trial, making sure that the trial fits the diverse patient population that needs to participate. We also hear from patients about their values and how they weigh the values of various benefits and risks associated with the treatments and the treatment alternatives. And that comes to play and has a bearing on how we as regulators make benefit risk decisions for medical devices. We like to hear from patients about how to best communicate benefit risk back to the patient community. And we know that it's not a one-size-fit-all type of solution, that those solutions need to be tailored for various communities that need to use them, whether we're talking about children or women or people who are not primarily English speaking. And then lastly, patients are a critical element in our boots on the ground surveillance system. They can let us know when medical devices are not working well so that we can be swift and definitive in our enforcement actions to try to make sure that we ensure we are protecting and promoting public health. So I talked about the importance of including diverse patients in the design of studies. We've talked about the importance of demographic variables in general. But one of the things I think COVID-19 has very clearly taught us is the importance of thinking about diverse populations on the forefront and not as an afterthought. We saw differential health outcomes in patients who were faced with COVID-19. And some of it had to do, some of it was associated with older age, comorbidities, and some differences were seen in people of African descent as well as the Latinx population. The challenge with this is that people wanted to ascribe biology as a cause. And I would caution us to not make those assertions, but see that there's a difference in a pattern of disease outcomes and try to understand it. And we'll talk a little bit more about that. We know that there are some true biological reasons why people might have different experiences with medical devices. In fact, ionizing radiation is more impactful in pediatric patients because their cells are turning over at a much more rapid rate than an adult. We also know that women tend to have a more robust inflammatory response, which is why we see different patterns of autoimmunity in those communities. So there may be some biology behind it, but I say that it's important that we start to collect that information and be intentional about that collection so that we can at least begin to explore the reasons as to why. In order for us to collect it, we have to agree on the language. So let's start first with race, ethnicity, and ancestry. Race is a social cultural construct. It is a legal definition. In fact, it has been codified in many countries as well as this country about what defines race. So it's not biology. And our Office of Management and Budget has made it very clear that it is not a biological phenomena. And as you probably know, the Office of Management and Budget is what governs all of how all federal agencies as well as federally funded work should collect on race and ethnicity. Ethnicity is different than race, but is connected. It refers to the shared cultural, social factors that bring people together, that common heritage, that nationality, being from a similar country of origin. It maybe helps to define what they eat, the type of cultural behaviors that are considered acceptable and what their ideas of beauty are. Ancestry is different. Ancestry is getting at particularly the genetic elements, the lineage of people, where they come from and where their roots are. Though these three words are connected, but are not synonymous. And I would urge us not to conflate the three words. The Food and Drug Administration has come out with a number of different guidance documents to try to encourage standardized, systematic collection of information about race and ethnicity in medical product studies. The first guidance was put out by the Office of Minority Health and Health Equity at our agency in an effort to collect it in a structured way. The other three guidance documents that you see listed on the slide are for medical devices as well as biologics and drugs, and how trials done in those areas should collect information on race and ethnicity. Guidance documents are our recommendations to industry, to other stakeholders who are doing research and want to submit it to the FDA for consideration. So at what stage is it important to consider the various demographic groups and collecting information on race and ethnicity? I would say, as I told you before, across the total product life cycle. But most importantly, let's start first with the trial. The trial needs to be designed in a way that it collects information from diverse patient populations in order for us to make any inferences or decisions about how a product performs in those populations. The challenge is that we are doing trials today on the history of significant injustices that have been done in communities of color, as well as people of various ethnic groups, and in people who are in vulnerable situations, such as people living with mental health conditions and in the prison system. So that historical knowledge and that embodied distrust can really impede people's willingness to enroll in clinical studies. So we have to take steps. We have to be proactive and create a system of trust that will encourage people to participate in trials so that we know how the products work in different populations before people are subjected to them widespread. And so our guidance document is encouraging the enrollment of diverse populations. We have seen in the studies that have been done in the years of 2009 through 2012 that there are big gaps in what type of demographic data is being collected in our device clinical trials. In fact, race and ethnicity was only collected and reported to us in 27% of those studies, and only 16% of them were in the public-facing documents. So very little information for healthcare providers to make decisions about how a device may work in a particular community, particularly an African American or Latinx population. The only way we're going to tackle this is by planning for it, and that's by planning for diverse enrollment. Being proactive, thinking about which groups that you need to have participate based on how severe the disease in a particular population, how prevalent is that condition in that population, and then also considering what are the past studies that have been done, what worked, what hasn't worked, and learn from them, as opposed to reinventing the wheel and repeating past failures. Some of the efforts that we have really asked the community, the industry, to consider as ways to improve the diverse patient population is to include investigational sites that have access to diverse patients. That means partnering with patients, providers, in communities, community leaders in communities of color and of diverse linguistic backgrounds so that you can bring those patients into trials, but not just stand up a trial and then depart. Create infrastructure that leads to sustained engagement, partnering, and being reciprocal, not just taking from the communities, but also giving back. The other thing that we've also encouraged is to understand why you have low or no inclusion of patients from various demographic groups. Ask the communities, figure out what the barriers are, and then take strides to improve them. The last thing is to remember that they are people living with a medical condition. They are not just patients. As such, they have social roles and responsibilities, and that we should be mindful of that. That means providing childcare or transportation coverage if needed, thinking about elder care and other elements that may make it more difficult for them to come in during our usual work hours for the trial. So those are solutions that we've put forward in some of our guidance documents. We understand, though, that data doesn't stop being generated at the clinical trial phase. It is generated every day by all of you in your healthcare setting. Your electronic health records are increasingly being used as real-world data to help inform medical device decision-making as well as decision-making for other medical products. It's the claims data that are being submitted to CMS and other bodies are being used to help inform healthcare decisions as well as not only coverage decisions, but access and pricing. And all of that information can be better informed if we have populations that represent the population that will be using those products. We've put forward a guidance document about real-world evidence that's being used in the evaluation of medical devices. And this guidance document talks about how to generate robust and reliable data that can inform medical device evaluation so that we can potentially expand the labeled indication or pick up safety signals proactively. I'm an ophthalmologist by training. I actually went to Spelman College and then did my medical school work and residency at Hopkins. And as part of the work that we've done, I've been interested in differential response of certain groups to different therapies. Glaucoma is a condition that is more common in patients of color and patients of different ethnicities. And so we were curious as to whether these new devices, called minimally invasive glaucoma surgical devices, perform differently in people of color, because our trials that were submitted to the FDA did not have adequate numbers for us to understand that performance of the device. We leveraged the IRIS registry, which is the largest actually registry in the United States. It's comprised of 60 million patients with 325 million clinic visits. It pulls data from the electronic health records of 80% of the ophthalmologists in the country. And that data is then used to better understand the health outcomes of various patients with certain medical products. What we found is that African Americans, men, and people of older age were more likely to use minimally invasive glaucoma surgical devices, but people of Hispanic origin were not. So we were seeing differential patterns of the devices being even offered or used in their treatment. The other thing we noticed is that African Americans had better outcomes with these devices, which is important for us to understand. So the question is why? Is it because they're being offered at an earlier time in the course of their disease? Is there something else happening that's allowing the device to perform better? But the other thing we have to be very wary of is it because 12% of the data on race and ethnicity is missing? And actually, more data was missing on ethnicity. 12% of race was missing, which accounts for 7.2 million people, which most likely would probably be people who are of African descent or of Hispanic or Latin ethnicity. So this differential missingness may be informative and may completely change the inferences that we were able to draw from the data heretofore. So I want to talk a little bit about how important it is for us to collect race and ethnicity data in our electronic health records because of the ways in which it potentially could be used to improve the health outcomes of our community. The first, based on the Office of Management and Budget's recommendations, is to ask ethnicity first. And then secondly, ask about race, allowing patients to self-report and select as many categories as is relevant for them. The intent of this is to ensure that we have accurate reflection of race and not people's misrepresentation of race by looking at someone and ascribing them to a particular category. There are opportunities for more detailed collection, but the systematic way of collecting this information allows us to talk the same language, whether we're looking at our claims data for how we're billing for certain procedure, or if we're looking at a clinical trial that's submitted to FDA. The challenges, however, that we're seeing with race and ethnicity data is that people aren't doing this. In fact, we don't know who's reporting it. We don't know what categories they're using. We don't know how they're defining the categories or how they're handling missingness in the database. And so that brings to mind a lot of problems with the evidence that may be submitted. Electronic health records are just one type of real-world data. We're seeing patient-driven registries, provider-driven registries, and particularly in the space of cardiology, there's quite a few, as well as orthopedics, and insurance databases. All of this real-world data, if it's misclassifying people with respect to race and ethnicity, can be very problematic in terms of the conclusions that are drawn, the social programs that are subsequently funded, and the improvements that could be made on medical products to treat our patient communities. I want to share with you a little bit of literature that we're seeing on the data that's being collected in the electronic health records. 11 to 22% of hospital systems are not collecting any data on race and ethnicity. And this is 2000 data forward to about 2010 is where this data is drawn for. You saw from the IRIS registry I shared that 12% of the data was missing for race. There are cancer registries like the SEER registry, which is one of the largest supposedly representative registries in the country. Well, 18% of it is missing race and ethnicity data. And some of this may be for various reasons, which we'll touch on in a moment. But some of the challenges that I've talked about before is the importance of understanding that misclassification is happening. People of various ethnic backgrounds and racial groups are being classified as white inappropriately. We're also seeing that race is being collected and reported by others because there is no systematic way of putting it into the electronic health registry. We also know that systematic racism is playing a role. A survey of California residents, about 400 of them, looked at whether they would put report their own race or ethnicity and why they wouldn't. They found that 17% of them were uncomfortable reporting their race and ethnicity, and then 46% were concerned that it was going to be used against them in the delivery of healthcare. I think this is really a cold splash of water to the healthcare system. In particular, we saw in the JAMA publication that came out, I think last month, where they not only did the editor speak to implicit bias, but the journal actually came out and started looking at the publications and saw some systematic racism in what was being published. So there's a call to action. And I think, as you all have already alluded to, it's important that we acknowledge it and start to address it. The last place that I'd like to highlight the importance of collecting demographically diverse information is in the construction of tools that help us better understand the performance of medical products. Those tools can be measures of patient-reported outcomes, for example, how patients are feeling and functioning, and they are self-reporting that. The challenge is if the only functions that we're collecting on are functions that resonate with a primarily white population, but not necessarily a population of Hispanic or Latin descent or African descent, then we may not be reflecting the outcomes that are important to them. The other thing that we have to be mindful of is language and how people express how they feel. If we're only collecting it with one particular cultural background being considered, then you can imagine the misclassification and the errors that we may be having in these tools when they're used in other populations. Our center has been taking a stride towards trying to explore this mismeasurement that may be occurring, as well as confirming whether that it's not occurring in some cases by doing studies, exploring diverse patient populations and how they are reporting on how they're feeling and functioning. We're also looking at how new technologies are being used and their receptiveness to new technologies, because we often hear that that's the barrier for why people of color are not using certain types of devices. I think we've got a lot of challenges and a lot of opportunities. One is that we should start harmonizing on using the terminology consistently and appropriately so that we are mindful of what we're talking about. If we're talking about race, that may be a very important issue when we're talking about access as well as discriminatory practices within the healthcare system. If we're talking about phenological causes or genetic causes for why something may be performing less well in one group than another, then we should really be looking at ancestry and not using race as a proxy, potentially inappropriately. We should also avoid burdensome and exhaustive categorization, as well as systematically take approaches to collecting this in the delivery of care. We've got to prioritize it and make sure that our healthcare records are reflective of the patients that we're caring for, and creating IT systems that support that integration. And then lastly, we need to involve the patients. We need to bring them in and help understand what are barriers to them reporting and help mitigate some of the negative impacts that could come with them reporting their race and ethnicity. I think the time is right for us to all work together and to try to better understand how medical products and medical devices in particular are working in our patient populations. Thank you very much for your time and attention, and I will turn it back to you, Dr. Sanders.
All right, thank you very much. If you'll stay with me for a few moments, I'll see if there are any questions or any discussion.
I have one question, and this is Dr. Linda Walden in family medicine. And since you're from the FDA, even though it doesn't have to do with race or ethnicity, my question to you, you know that cigarette smoking is people who smoke cigarettes, they're taxed on it. Do you think there'll ever be a tax on eating beef and pork, which causes cancer, which contributes to climate change? Do you think that'll ever happen?
So I can't speak to the other product centers. I am specifically devices. I don't know. I mean, I think it's something that we'll have to see. I think that there's a lot beyond taxing that we could potentially do as well to try to help improve some of the health behaviors of communities. And I think that there's some efforts that I know are underway, but I don't want to speak for my colleagues across the other product centers. But thank you for the question.
Yes, thank you.
Any other questions? Dr. Trevor, I really want to thank you because I think that was a very well thought out talk. and very excellently delivered. You shared with us the range of activities at the FDA, but you also focused in on the use of language around race and how important consistency and how it impacts so many activities. And I think this will really help us as a group learn how to at least think about a course to assure that we get appropriate and fair use, both in collection and how that information is used. So thank you very much.
My pleasure.
All right, next, I'd like to go to Dr. Yolanda Wimberly. Dr. Wimberly is going to talk to us. Dr. Wimberly is with Morehouse School of Medicine, where she serves as the Associate Dean for Clinical Affairs. I have the pleasure of working with Dr. Wimberly almost every day. She's going to talk to us about the future of medical education, both at the undergraduate and graduate level. Dr. Wimberly.
Hello, everyone, and good evening. I hope you guys are had a great day and a great week, and really looking forward to an invigorating weekend as we have our first virtual conference. So first, I'm going to start off with some of the ACGME updates for graduate medical education, and then talk about some of the undergraduate medical education updates that will pertain to the medical school. Let's see. So if we look at ACGME, for those of you who may not be familiar, is the accreditation agency for graduate medical education, which will be our residency and fellowship programs. And there have been quite a few changes on the landscape as far as ACGME is concerned. Some of you may know that we now have a single accreditation system. So whereas we used to have allopathic and osteopathic accreditation, as of a few years ago, that actually merged to be one system under the ACGME. As a lot of you are very well aware of duty hours, but there have been some refinements and changes to some of the initial duty hours rulings that have come down since 2006, and we'll go through those just very briefly. The clinical learning environment, or what we call the CLEAR visits, which now we'll talk about in a little bit, but now what that does is that incorporates the hospital systems and looking at their patient safety quality improvement systems as you evaluate GME programs. And then also our ACGME Office of Diversity and Inclusion. And hopefully you guys have heard from either Dr. Bill McDade and or Dr. Bonnie Simpson Mason, whether it be at GSMA or at the National Medical Association or some of your specialty association groups. And in addition, I'm going to give you a brief overview of the HBCU ACGME update so I can remind you just how much of an impact our HBCUs medical schools have had on the increase in the number of URIMs in medicine. So for the single accreditation system in 2014, the ACGME, AOA, and AACOM agreed to create a single GME accreditation system. And by 2020, that system was achieved. What does that mean for us? That just means that now pretty much the NRMP, which is the match system a lot of people are familiar with, DOs as well as MDs actually both participate in that system exclusively for residency programs. All of the original DO programs actually applied for accreditation with ACGME, and approximately 85% of those programs were approved and are now ACGME programs. And so there's no real difference between the accreditation agencies. There's only one agency that accredits both DO as well as MD residency programs. And what this single accreditation system, some of the benefits of it were high quality uniform GME accreditation, increased collaboration among the medical education community. It reduced costs and increased efficiencies, and also eliminated the need for those programs to really choose between an MD or a DO accreditation pathway, because now they're both combined. It also provided consistency across all residency and fellowship programs. So it was a standardization, and it offered all U.S. medical school graduates a uniform graduate medical education pathway. So it's just really one pathway, while also protecting and preserving the osteopathic medical education and all the essential things that come along with that. Moving on to CLEAR. CLEAR is an acronym for the Clinical Learning Environment and Review. And there are 6 focus areas that we look at when we look at CLEAR: patient safety, healthcare quality, transitions in care, supervision, well-being, which includes your duty hours, fatigue management and mitigation, as well as professionalism. And what the CLEAR visit does is it occurs once every 18 months. And instead of coming into the residency training programs or the fellowship training programs, it comes into the hospital system. And Dusty is very familiar with this. That's why he's smiling. And what this does is this includes the CEO of the hospital, as well as the CMO, and a lot of the senior administrators. And what ACGME does at that point in time is they talk to them about the clinical learning environment for the residents and fellows, because oftentimes when you just talk to the programs, they may not be able to control as much as what goes on in the patient care settings that the hospitals do. So it is an attempt to actually get a true understanding of what's going on in the learning environment for all of our learners. Duty hours. Looking at the duty hours, some of you all may be familiar with the I Compare and the FIRST. So initially, when the duty hours were put into place, we had an 80-hour work week that was instituted, that was averaged over 4 weeks. In addition to that, there were other things such as maximum out at 16-hour calls. If you did a 24-hour call, you had to be gone 4 hours later. And so there were lots of layers to what those duty hours looked like. The purpose of that was to actually increase patient safety of the learning environment. This I Compare in the first trial, which actually Morehouse School of Medicine was a part of, what they did was they initiated a study to see the impact of the duty hour requirements on those education and patient safety. And it'll allow for residents in the test groups to follow more flexible work hours. So what the studies found was that the results of the studies were that there was no decrease in patient adverse action events. So this was actually quite perplexing because of the fact that a lot of the institution of the restrictions on the duty hours was thought to be because of patient safety. These studies showed that there really wasn't a difference in the patient adverse events. So it led us to 2 things. A, we still needed to find a way to be able to decrease the number of patient adverse events. And B, we then had to decide what was it that we can do in the learning environment to be able to affect that. But because of these 2 studies, of which Morehouse School of Medicine was a part of, some of the duty hour restrictions were kind of loosened. Most of them being the overnight call restriction, as well as the maximum amount of hours that can be worked. The 80 hours was kept, though. And so it's just important for you all to know that. Most of you may know this already, but this caused probably about a year ago a loosening in some of those restrictions. And so now you may hear residents and fellows talk about the fact that they do overnight call more frequently now. A lot of systems, though, quite frankly, especially even us at Morehouse School of Medicine, we had already made those changes. And so you'll see that a lot of systems just continue with the changes that had already been made. Now, I wanted to really have us look at what the HBCU impact is. At this point in time, there are 4 medical schools that are historically Black colleges in the United States that actually have medical training. And so I want us to just really kind of visit what that impact has been on the medical community. Howard University, I might have a few people on here that graduated from Howard University, maybe your alma mater, whether it be undergraduate or medical school. But this medical school accepts about 120 new medical students per year. Their GME has graduated approximately 1,400 residents since 2001, with 53% of those residents being African-American and 410 being males and 335 of those being African-American women. 41% of their graduates practice primary care upon graduation. And then we have a list of all of the residency and fellowship programs that are at Howard GME programs currently. And as you can see, this is a pretty extensive list. Majority of them are residents, but we definitely have quite a few fellowship programs as well. The chart also outlines their original accreditation date, their authorized complement, their authorized positions, and also their field positions. And so for a total of 237 authorized positions, and all of those positions have been filled for Howard University School of Medicine GME programs. Next is Meharry Medical College, which is my alma mater. Located in Nashville, Tennessee, Meharry was established in 1876. And with Meharry, they have 3 separate schools under its auspices: the School of Medicine, the School of Dentistry, as well as the School of Graduate Studies and Research. Each year, the medical school accepts approximately 115 new students, about 60 to 70 new students to the dental school, and 73 in the grad school and research students. GME at Meharry has graduated about 544 residents since 1997, of which 62% of the graduates are African Americans. This looks at the list of the residency programs that we have at Meharry Medical College to date and their original accreditation date. As you can see, Meharry has the majority of residency programs and has 1 sports medicine fellowship program. Next, we have Charles R. Drew University of Medicine and Science. This is a private nonprofit institution that's located in South Los Angeles. At its peak of its original GME programs in 2006 to 7, Charles Drew was sponsoring 14 residency programs and had 238 approved resident positions. They had graduated 2,700 residents from 1971 to 2007, and 32% of the graduates were African American, with 49% practicing in primary care. And these were the residency fellowship programs that were offered at Drew at that particular point in time. And as you can see here are the remaining, these are the authorized complements, the positions, and then those that were filled. These are the current programs at Charles Drew that they have currently, which is family medicine and psychiatry. So they went from having about 238 authorized resident positions to about 30 authorized resident positions, 14 of which are filled. And last but not least, Morehouse School of Medicine, located here in the state of Georgia, in Atlanta. We offer 7 residency programs and 3 fellowship programs. Our undergraduate school takes 100 medical students each year. And we have graduated actually a total, I'm going to include this year's numbers, a total of 985 residents since our first program in 1981, with about 45% now being African American, 141 males and 231 females. 60% of our graduates practice primary care upon graduation, and about 65% remain in the state of Georgia. This is a listing of all the residency programs, as well as fellowship programs, their original accreditation date, and their authorized complements and field positions that we have currently at Morehouse School of Medicine. This shows you, this is just a graphic that shows you the Black African American of all of our residency stats from all of our graduates, about 42%. We do break down between the African diaspora. And so we have about 23% of our graduates that would identify as African, 42% African American, and then you can see the rest. 21% Asian, with the majority of the Asian residents, that people that identify as Asian coming from India. This looks at our incoming resident demographics from last year. As you can see, probably about almost close to half of our class coming in every year, including this year, identifies as being African American. This is looking at our African American male graduates by program. As you know, there has been a big push and a mission of Morehouse School of Medicine with Dr. Montgomery Rice. And so we actually do follow those statistics as well, with about 25% of the graduates coming out of family medicine being African American males, with a low of 2% in pediatrics. This graph looks at all of the HBCUs across, so from 2001 to 2018. I'm sorry, this looks at Charles Drew is only from 2001 to 2006. But if you look at all of the 4 HBCUs, there have been a total of 2,900 graduates from the 4 HBCUs. 59% have identified as Black. And with the aggregate data, Blacks can include Africans, African Americans, and Caribbeans. So as you can see, the impact that we have in particular as HBCU medical schools has been huge as far as us graduating not only from medical schools, but also from residency, African American physicians. And just really quickly, this is Dr. Bill McDade, which a lot of you may know. I don't know if I've met too many people that don't know Bill McDade. And I work very closely with him at the ACGME, as Bill oftentimes does present nationally about diversity and inclusion with ACGME. He was named their first Chief Diversity and Inclusion Officer about a year and a half ago. And one of the things that Bill, as well as Bonnie, have been working on is just an adjustment to our program requirements with ACGME to be able to, first of all, enforce the need for diversity, but also to measure it in outcome measures to ensure that it is occurring. And so what they're typically doing, I'm going to kind of go through this a little bit, is just, I want to show you this graph that shows you currently about 4% in general of all residents in training are identify as African American. And as you guys know, probably about 4% of all practicing physicians in the United States are African American as well. And so that's really important to understand, because as we want to increase that number, our pipeline really has remained the same for the past couple of decades. And if there's not some type of drastic change, will actually remain the same in the future. And as you guys know, African Americans comprise about 12 to 13% of the population. Does diversity matter for health? We all know that. Black subjects were more likely to talk with a Black doctor about their health problems. They're more likely to write additional notes about the subjects from the physicians. And they were nearly 20% more likely to return for preventive medicine appointments with a Black physician. Studies have shown that cardiovascular disease impact was significant when folks had people who were Black doctors had take care of Black patients. And then what I thought was really interesting, flu shots were very significant as far as the increase. And we probably could put COVID in there as well. I will have my slides available. In the interest of time, I'm not going to go through all of them, but I did put them all in here for you all to peruse through and have them as a resource if you wanted to know further information. But the rest of the slides are just information about diversity within the GME as well as UME sector. I just wanted to take a few minutes just to talk about UME in particular. A lot of times there are a lot of differences, there are a lot of similarities between UME as well as GME. And as you know, on the forefront for UME, some of the things are going to be looking at the medical school curriculum. A lot of medical schools have already changed over from the traditional school that we maybe have been used to small group learning, lots of virtual learning, lots of technology that's infused, simulation also that's infused. It's also important as far as medical school admissions for us to understand what the pipelines are looking like. As you guys probably well know, there's been the same amount of medical school applicants from African Americans, the same since 1985. There really has not been any change. And when we look specifically at African American males, it has remained flatlined. As you know, it is important for us to ensure that within our communities that we're looking at the pipelines that we're offering. I would really beg of you to look just in your own community. What are some of the pipelines that we have? What are some of the things that we do as African-American physicians to uplift those and to mentor those who are younger than us coming behind us? And what are some of the strategies that we're using to be able to increase the number of URIMs in medicine, particularly African-Americans? Medical schools are increasing in their size, but what we've seen overall is that number of URIMs, even with the addition of about 10 to 12 new medical schools within the past few years, as well as the enlargement of class sizes, has not really resulted in an increase in the number of URMs that we're seeing that are matriculating through medical school. So really just keeping your eyes on that. Being able to really have some think tanks around, what are some of the things that we can do with the pipeline to be able to increase that are going to be very important for us as we continue to train this next generation of physicians to be able to take over and allow us to really sit down and retire and know that we're in good health. I'm going to stop right here in the interest of time. And at this time, I'll hand it back over to Dr. Sanders, but I'm definitely open to any questions or comments that the group may have. And thank you.
Thank you, Dr. Wimberly. Any questions or comments?
Yes, this is Linda Walden. Thank you, Wimberly. That was excellent. My question to you is, do all of the medical schools, are they required now to have diversity and inclusion faculty? Directors?
There's not a requirement that they have to have DEI directors. Most of your medical schools, though, have some type of, in the LCME guidelines, cultural competency. Mm-hmm. So like cultural competency courses or some type of curriculum, they have to do some type of training in that, but not that they have to have a person that is specifically identified. You'll probably find a lot of them do have people that are identified, but that's not a requirement that they have to have that.
The reason I asked that is because I have a lot of students, mentoring students and those in residency. And I'm seeing that a lot of these young people are experiencing a lot of systemic racism in training, and they don't have anyone to go to within their system of training. So they end up calling those of us who are mentoring them to share what they're going through. And this is terrible. Many of them want to stay in small areas. And when they get in groups, they may be the only Black resident in their group. And the white doctors are talking to the rest of them about staying and what they're going to do for them if they stay. But they don't talk to some of the Blacks about that. The second thing I want to also say in terms of why we're having a problem with increasing the pipeline, we have to also look at 67% of Black children are raised by single parents, mothers. And, so there's a serious problem there with a broken family when you don't have young Black men who are interested in medicine, because number one, they don't have the funding. The moms are working every day trying to take care of the family and put a roof over their head, most of them. And they just look to go into sports because they figure they'll get a scholarship easily through that. So that's one of the big issues that I'm seeing in my area is, we wanted to try to help Black boys get into Meharry Medical School when they had all of these kids could get free medical school training and college training. Couldn't find anyone. I spoke to 7 schools. No Black male could they identify. That's a serious crisis.
You are correct. And I'll tell you one thing just anecdotally that I've even seen. I mean, I have 14-year-old twins and I have a boy and a girl. And what I do see is that a lot of times when we start these pipelines, we start in high school. A lot of these kids, especially my kids and their friends, they've decided by 3rd, 4th grade what they're not going to do. They may know what they're going to do, but they know what they're not going to do. And a lot of that is based off of elementary subjects. If you look at elementary science teachers and elementary math grades, a lot of kids are taught that if I'm not good in math or if I'm not good in science and I'm not getting A's, then I can't be a doctor. Right. So when you may oftentimes ask them in the 5th and 6th grade, what do you want to be? They'll say, I don't know what I want to be, but I know I'm not going to be a doctor. So I think we have to really, a lot of our pipelines have looked at high school I personally feel like high school is probably a little bit too late to catch that increase. You're going to get the folks who really want to do it. That's great. But to catch those folks before they decide they don't want to be a doctor,
Yeah,
in my opinion, we've got to reach down to the elementary school level.
definitely.
Look at those elementary school science teachers and those elementary school math teachers, because that's where the key is right there. Because by the time they get to middle school, those kids have already, if you ask a middle school kid, what are you good at? They'll tell you what they're good at, what they're not good at, and that follows them the rest of their lives. And so I think definitely your points are well taken. I would love to see us do more pipeline programs, getting down to those elementary and pre-K kids, even pre-K kids, so that what you're doing is you're saying you don't necessarily have to be a whiz at math. That's what calculators are for. You don't exactly have to be a whiz at science. You know, that's what the internet's for. And so I think we've got to really change that messaging.
Yeah, definitely. And just make sure that our elementary school teachers are inspiring our young Blacks, because they're not. I can
Yes.
tell you, my cousins come and tell me, they say when they raise their hand to answer a question, the teachers overlook them and let
Yes.
the whites answer. So we're seeing that all the way down in that level. So
Yes.
that's sad. That's
Yes.
really sad.
Hello,
All right, any other questions?
this is Dr. Manson in Chattanooga. When I was growing up, I see a lot of white physicians carry their kids to make rounds, but I see lots of Black physicians don't really do that until the children get older. So basically, those children are impacted by the parents. It used to be doctors, children became doctors. Now you find it's not happening. So can you address that?
Yeah, I'm glad you said that. That is key. Exposure, exposure, exposure. And there was a documentary just came out at the beginning of the year, White Men in Black Coats. If you guys haven't seen it, you should look that up. But they talked about that. Our young Black men talked about that exposure and knowledge of what's in the community, and being able to see that. So it doesn't always have to be some type of a formal educational type of experience, but taking your kids to the hospital on rounds with you and just exposing them to that group. And also, I think it's very important for us too, as physicians, and I'll tell you, my kids mentioned this to me, is being happy with what you do. Because sometimes if we gripe and complain and this and that, we have to remember they're impressionable. And, they'll be like, you know what? My mom or my dad is always busy. They're always, mad at something. I don't want to be a doctor. So they really do affiliate a lot of that. So we have to be very careful about that as well. But definitely exposing any opportunity that I get that's safe. I'm bringing my kids with me to the job just to show them exactly what that means and to really show that in a positive light. And I think we've got to be really intentional with being able to do that and show that in a positive light. And then one last comment on that is in the documentary, they talked about how you don't know who Black doctors are, because what happens is when we go out, right, into the community, what do we say? What do you do? Oh, I work at the hospital, because you don't want to brag, right? You don't want to say, you say you're a healthcare worker, right? And so what they taught me in the movie was, say you're a doctor. So now for the past 6 months, people say, what do you do? I'm a doctor. Yes, I am. Because what happens is that lets people know who you are. It's not bragging, but it shows other people who don't know, who may be impressionable, that's what a doctor can look like.
Very good.
Any other comments? Thank you. I want to thank both Dr. Wimberly for her talk, but I want to thank Dr. Walden for triggering a conversation about the pipeline, a real conversation about the pipeline that really hit on the forces that impact our children early on, and how we as an organization and how we as a group of people can counteract that. Dr. Wimberly, thanks for really laying out the forces that are impacting those in the education system. Kind of the challenges and the successes of HBCU programs, and what we can do as an organization to help create the environment for good education across the spectrum. So thank you very, very much. These are the two topics in our first discussion. I now want to turn the program over to Dr. Winston Price, who's going to take on the next part with medical education. Dr. Price.
Thank you very much, Dr. Sanders, and that was certainly a very stimulating part of the program, and covered a whole host of issues that were critical with regard to medical education and also with regard to where we are with healthcare in America. So at this time, I have the pleasure of introducing an individual that I believe is destined to not only become one of the top clinicians in America, but is destined to be one of the medical correspondents at one of the major channels. I met her during her clinical rotation at my practice, and it's none other than Dr. Bria Carruthers, who is now at PGY1 at the Tinsley Harrison Internal Medicine Residency Program at the University of Alabama in Birmingham. She graduated from the Medical College of Georgia in Augusta. Her current interests include transitional care and survivorship in sickle cell disease, benign hematology, diversity, equity, inclusion in graduate medical education, and the list would go on for about an hour if I told you the amount of involvement in the community with regard to programs she did during her medical education. So at this time, without further ado, she's going to lead as moderator for a very dynamic group of individuals who are in various stages in medical school, and it's apropos based on the prior presentations to hear from the front lines in terms of their experience in medical school and beyond. So take it away, Dr. Carruthers.
Thank you, Dr. Price, for that great introduction. I just want to say thank you. Dr. Price has been in my life now for 2 years. I thank you for being my mentor. I was almost in pediatrics. We were fighting towards the end, but I continue to thank you for all that you are doing for me. And now that I am in graduate medical education, I'm so excited. My goal is to help improve diversity, equity, and inclusion in graduate medical education, hopefully throughout the country. But for right now, I'm just focusing on Georgia. So that is my goal. Before we introduce our panelists, I'm going to give you guys a little bit of a background that I wrote up. And so, as we all know, racism and social justice continue to impact the medical education of underrepresented minorities across the country. With the most recent killings of George Floyd, Breonna Taylor, and most recently, Ahmaud Arbery in our own state, Black and Brown medical students find themselves fighting two different battles, one through the lens of the world and also one through the lens of medicine. A panel of esteemed students from around the state will give you a glimpse into how we are fighting to improve systemic racism in medical education. Hopefully, this will spark great conversation, as we've already said. And I want you guys to please feel free to ask questions. We've had some questions that have already come up throughout the different presentations about what's going on. Pick the students' brains. One of my mentees, now she is an M2, Allison Lewis. She knows I will call on her because we need to have these conversations, and I'm looking so forward to hearing from the other panelists. So I do have you guys' names listed here. So I'm gonna start first with Kayla Hurst, who is class of 2022 at PCOM Swanee. Kayla, if you could unmute.
Sorry, can you hear me now?
Yes, I can.
Hello, good evening. Happy to be here.
Give us a little introduction, just let everybody know like
Okay.
that. No, you're fine, you're fine.
Very good. Okay, well, hello everyone. My name is Kayla Hurst. As said, I am a fourth year medical student at PCOM Georgia's Swanee campus. I am originally from Tuscaloosa, Alabama, and moved on over, moved on over to Atlanta to attend Emory University for my undergrad, and also attended PCOM Georgia for my master's as well. And currently now fourth year, I am currently holding the Region 4 Director position for the Student National Medical Association. And with that position, I sit on the board of directors at the national level and preside over all of the SMMA and pre-medical student chapters within the states of Georgia, Florida, Alabama, North Carolina, South Carolina, and the Caribbean. So very happy to be here. Thank you.
And what are you going into, student Dr.
Oh, yes. Because the match is happening soon. I plan to apply into dermatology. So everyone pray.
Awesome, awesome. Okay, next on my list, I have Brian Johnson, class of 2023 from the Medical University of the Americas.
Good evening, everyone. I'm sorry, can you guys hear me?
Yes, sir, we can hear you. You're good.
Good evening, everyone. I'm excited to be a part of this panel this evening. I look forward to sharing, my insight and any questions you guys have. Just free to share with you guys.
Okay, awesome. Next, I believe that we have Mr. Rick Bowen's class of 2025, who's at Mercer School of Medicine.
Hi, everyone. I'm Rick Bowens. I'm actually class of 2024. So I'll be graduating in about 3 years at Mercer University School of Medicine and the Savannah campus. A little bit about me. I did undergraduate at University of Georgia. I was born in Albany, Georgia, and then was raised in Lawrenceville, Georgia, majority of my life. Went to University of Georgia, did my 4 years of undergraduate there in biology. From there, I went and did an MBA program with Mercer. And then from there, before I went to medical school, I did a master's at Case Western University in Cleveland, Ohio, where I majored in medical physiology. And then I came to Mercer University School of Medicine. So I'm happy to be here and looking forward to the discussion.
Awesome. And then I have student doctors Ward and Arawoto from PCOM South Georgia, class of 2024.
Hey everyone, my name is Oge Chukariwodo, but everyone calls me Ari because it's a lot easier, obviously. I'm originally from Nigeria, born and raised. I did my undergrad at the University of Central Oklahoma in biology, and as soon as I graduated, I enlisted in the Army where I served as a Army medic for the past 5 years, and I recently just got done with my first year actually at PCOM South Georgia. So I'm happy to be here, really excited to have this conversation underway. And hopefully we can both learn and teach each other something, a thing or two. Thank you.
Good evening, everybody. My name is Ivana Ward. I was born and raised in Mobile, Alabama. I graduated from Tuskegee University with my bachelor's in nursing, worked as a nurse for 4 years, did a post-bac program at University of Florida, and then now I'm at PCOM South Georgia, just finished my first year of medical school, exciting. I'm excited to be here and talk with you guys.
Okay, and then lastly, I know her name is not pictured, but she's on my list, and that's Allison Lewis at the Medical College of Georgia.
Yes, hi everyone. My name is Allison Lewis, and I like my colleagues have said, new second year student at the Medical College of Georgia. I am originally from Dawson, Georgia, small town of Dawson, Georgia. I went to undergrad at Augusta University, and I currently serve as the chapter president of the Student National Medical Association. Kayla, hi. And I'm excited to be here and be a part of this conversation.
Great. And Amalaya, Dada may have slipped into the meeting as well. Are you there?
Yes, I'm here. Hello, everyone. My name is Amalaya Dada. I'm an MD3 student at Morehouse School of Medicine, and I was born in Nigeria, raised there, but also raised in Aurora, Colorado. I went to Norfolk State University for my Bachelor's of Science in Biology, and also got my Master's in Medical Science at Morehouse School of Medicine before matriculating into the MD program. And I'm looking to go into emergency medicine.
This is all very exciting. Okay, everybody else got to say where they were from, and I didn't say where I was from, Dr. Price. So I grew up, born and raised in Albany, Georgia. Fun fact, actually, Rick and I both went to preschool together, which is crazy. Like, that's how small the world is. And then I went to the #1 in the country, Spelman College, for my Bachelor's of Science in Biology before going to Hampton University to get my master's, and came back for med school at MCG, and now I'm at UAB. So Dr. Price, just let me know about the timing when you want us to start taking questions. But we have 5 field questions just to kind of ask you guys. Please feel free to just kind of jump in. It's basically a free-for-all, okay? So the first question that I have to ask you guys is, how do you feel like the MCAT, and for those who have taken the STEP exams, how has that impacted the potential entry for minority students getting into medical school and residency programs?
I'll go ahead and start. For me, the MCAT was like a stumbling block, just because prior to going into college, I knew I wanted to become a doctor, but I didn't know the steps that were necessary. And just like we talked about, those bridge programs, I think those are really, really important, because students can get that information early and start working on those things earlier on. But for me, I had to take it multiple times, but eventually I feel like practice is key, and just, starting that early, I think it's important, but it's not everything. Once you get into medical school, I think it's just weed out type of exam. And once you get it down and you understand it, you're on your way.
I'll speak a little bit about that. I think one of the biggest things is just the awareness of it. Like she said, is recognizing, medicine is one of those fields where you have to constantly, early on, you have to think about the future. When you're in high school, you have to think about already preparing for the MCAT. And I was behind on that. And because, like I said, being the first in my family to try to be a doctor is just some things that you're not aware of. You don't know kind of who to go to about some of those things. So, being in high school, you kind of already have to think MCAT. When you're taking your first class, it's preparing for the MCAT. First year of medical school, I just finished my first year, and on the first day of class, we're already talking about what can you do to prepare a residency application. It's like, that's 3-4 years away, but it's like, that's how the field works. So you have to have that, early exposure. I feel like getting a mentor kind of early on to help with that. But the MCAT is one of those things where it's very anxiety based for a lot of people of color, I believe. And one of the things I feel like it is because, for me, I held a high standard on I want to make it for my family, be the first doctor in my family. And I feel like we hold some of that pressure on us to succeed, where some of our white counterparts, maybe they aren't the first in their family, or maybe they come from a long line of doctors. So it's a little bit of a different route to get there. And so I think that's some of the anxiety that brings about the MCAT. But like she said, practice and getting someone who's done it before and kind of going back and reaching back to those students who have to go through that process and telling them, how can you do mistakes you made and how they can do it better really helps as well, I think.
I think just to kind of piggyback off of what you said, a big thing is I know from my personal experience, there's not a lot of conversation about the things that I did wrong, or conversations about the stumbling blocks that I had, or just very honest conversations about how to get there and what I need to do. And I think creating that space and making sure us as students here reaching back and doing that is super, super important, because there's so many times where the picture and the end goal looks like, oh, you made it to medical school, you're doing great, but we don't talk about those hard nights, how many times I've cried about something, how many times I didn't make it. And it puts, again, more pressure on students trying to conquer the MCAT and trying to conquer step one, because they feel like I'm failing because my path doesn't look like your path looks on this one picture. So having those very open conversations, I think, can definitely help, because we all feel like we're the only person having this individual struggle, and that is not true.
I just wanted to give a different perspective as someone who is currently in STEP dedicated, right? I would just like to piggyback on everyone and saying, yes, there is not enough mentorship early on for us to really know exactly what we're getting into. Then also when we're in the situation, when we're in dedicated, we're trying to figure it out, we aren't getting it while we're actually trying to work through it. And someone's just telling us, you're not hitting the mark, continue to study. That's not helping me. And I feel like there's several students that are going through that same process, and many of them are students of color. And then to put on top of that, that you have to focus and study while the whole world is really crashing down around you, in the sense of senseless killings of Black and brown bodies. And we're supposed to stay focused and be able to do what we need to do. And if we can't, and we don't get the score that they want, they say, well, what happened? I don't think that administrators and those that are in the positions that we're trying to get to as far as residency programs, and those that are over those, understand the gravity of what we have to continue to see every day and continue to act like it's just a normal day, and that we still have to get through these roadblocks and act like nothing is really going on and still perform like our counterparts who don't have to think the same about the same things in the same way because they aren't scared to go running outside. They aren't scared to just walk on the sidewalk and not be strangled or put or have a knee on their neck. I just feel like that is a part that many people in the last year have really had to cope with in a way that people have still not truly understood, even when I've talked to program directors so far.
Kayla, that's actually a really good point that you bring up. I'm gonna kind of interject, and then anybody who wants to kind of speak to that last question, you definitely can before moving on. But like you said, I think going through the process of, just getting through the match and all those different things, and you're asking people, what are you doing for diversity, equity, and inclusion? Because that's going to be a question that comes up, right? I think a part of that is one, they become ignorant to it. They don't understand, and they don't make that connection because that's not their community. It's just like, oh, it's another thing, and they're going to go about their day. And definitely how that can take a mental toll on you and dedicated, or like Allison, I'm going to pick on you because I'm going to pick on you. But Allison, going through M1, M2 year. And that definitely takes a toll on your schoolwork. It definitely takes a toll, mentally, physically, with what you're able to produce at the schools. And so our counterparts don't go through that, right? And being able to recognize and realize, and Allison will tell you guys, because I harp on it to her all the time, making sure that you are seeing not just performative action at the schools, but making sure that they're taking the steps that they need to make sure that you have all of the things in place so that you can succeed as a Black medical student. But not only that, for those who come after you, because that's so important. It's not just about you. I know that Allison and I've had other private conversations about, okay, what if I, do this, da 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 da. And for many of the reasons that some of the other doctors on tonight's meeting have talked about, they have to see you. They need to see you. Like Rick was saying, growing up, I didn't know anybody who was a doctor. My mom was in healthcare, but she wasn't a physician at the time. And so I had made mind, I want to be a doctor. Had absolutely no idea what a Black doctor looks like. I'm just like, oh yeah, I'm gonna be a doctor. And I went with that mindset, all throughout high school, all throughout college. But definitely a great point that you brought up, Kayla. And I wanted to just kind of like emphasize that and, kind of tie that up a little bit more. Does anybody else want to speak? I don't know if anybody else to the STEP exams at all. Because kind of like for the MCAT, like so many people have like mentioned, I think a big part of that also too is your not financial, but your fundamental learning before you actually even make it there, right? Because most of the time, Black students don't know how to study properly. And a big part of that is, whether or not you were taught. And the public school education versus private school education, majority of us probably went to public school. And my public school education was not the best, education. So if anybody wanted to just speak to that, or if not, we can definitely move on. I don't know if anybody wants to add to that.
I was just gonna
I'll definitely add. I'm sorry. Sorry, Dr. Carruthers. First of all, let me take 1 second to backtrack. I think I dropped off before the first presenter spoke, so I just want to backtrack and reintroduce myself. That's why I was kind of so shaky coming on. Briefly, I graduated from Albany State University with a bachelor's in psychology, a master's in public administration, and I have a certification in addiction counseling from, again, the unsinkable Albany State University. I think that was probably the gist of what I was going to say as an intro. Now moving over to preparation for MCAT Step 1 study. I have come to learn that, us as African Americans, we process things differently, and especially with everything that's been going on in the world as of late, it's, you kind of have to be able to put yourself in a space or a place mentally emotionally and spiritually in order to be able to cope. Now, I know that we as predominantly as African Americans may not have that skill set, but I think being exposed to individuals who have that skill set and who has the know-how to help us navigate through those spaces and places of, dealing with depression while, being in school as a medical student, or, whether it's wanting to learn how to, perfect your study habits or study methods. So I think all of that, I think there needs to be more emphasis put on, the how-to of, how to deal with things and how to matriculate and navigate through those spaces and places at different times of one's matriculation from undergrad or a master's program to medical school.
Perfect. And then Ari, jump in there and kind of tie us up on that question before we move forward.
Lastly, just a caveat, based off of what everyone has said, I read a study not so long ago that basically showed that there is no direct or positive correlation between a successful resident and people who scored high on their MCAT. And also there isn't really another study showed that they looked at schools that accepted students on a holistic perspective and looked at schools who kind of placed MCAT at a pedestal, and there was no difference between the success of the performances between students from both schools. So it's just sad that we live in this day and age where the MCAT is, even though right now schools are going towards the holistic perspective, the MCAT still plays a huge role in acceptance of students into medical school. I know being the first year, being the first generation immigrant, and being the first person from my family to even go to high school, let alone college. I know the amount of stress it was prepping for the MCAT, trying to study for the MCAT, so I wouldn't let my family back in my home country down. And I know I didn't have the best resources to prep myself for the MCAT. And I know the MCAT is a test that doesn't even measure the intangibles that are very important in making or modeling a great physician. All the MCAT does is just hopefully you don't have a bad day on this 7-hour exam or 7+ hour exam, and we go from there. So no matter what financial circumstance minority students come from back home or their socioeconomic status, I feel like the mental aspect plays a role as well in the pressure. You don't want to let your family down, and then you have folks who can barely afford the MCAT, because I don't know how much it is now, but I know when I took it was about, I want to say, 300 and something bucks for an exam. So that's a very expensive exam, and there's no refund fee if you don't do well. You have to buy another or pay for another exam and retake it. So it kind of puts all that toll on you, your mental psyche and everything, that you don't even study properly for the exam because of what if this, what if that, what if that. So as a result, we don't necessarily see a good representation. I'm not saying that's the main reason, but that's also a factor that we don't see a good representation or diversity in medical schools, because medical schools most medical schools want to base intelligence and intangibles off of an exam. But that was all I was going to say.
Okay. Student Dr. Ward, I'm coming to you next with my questions. So we're going to get everybody, okay? Dr. Price knows we're going to get everybody into the conversation, all right? But Ari, you bring up a really good point. Medical school is very classist. And with that, like you say, $300 here. I just realized I have to pay $1,000 for step 3. I was like, oh, nobody told me this. We don't get paid until, a certain time. And so what those financial barriers do are actually keep Black and brown people from applying. If you don't have the money, unless you have a scholarship or some type of way to be able to pay for these exams, right? And they continue to come. They do not stop. You pay for the then you pay for the materials for step 1. So Allison, all the M2s that are getting ready to study for step 1 and everything like that, that very first day of M2 year, they're going to be like, all right, this is the bundle packages. It's going to be $3,000. You need to show up because everybody in the class is paying for whatever the bundle, right? And then you make it through that hurdle. And then before you know it, step 2 is around the corner. You got to study for step 2. You need prep materials for that. And then you need step 3 and licensing and all these other things. And so it's such a good point. I think, there's big talk as to how we can eliminate some of those financial barriers. So thank you, Ari, for bringing that up. So student Dr. Ward, I'm going to start off with you. I'm going to switch my questions up a little bit. So how do you find that you receive sufficient support from your organization to address racism in medicine, like at the school? And if not, what do you think that the school could do better?
So to that question, I'd like to say, I feel like there's always room for improvement. There's always a way to do better. There's always a way to include people more. I know with our school, one of the things that we asked was that when they're teaching us about the different diseases that our patients are going to present with, that they present us with patients of different color. So when we started off, a lot of our patients were of the white race. Okay, that's fine. We're going to see that too, but we need to see what eczema looks like on a Hispanic person or a Black person or so forth. I think our school did a really good job of trying to implement that for a while until it kind of dropped off when we got busy into getting ready for the next set of courses and so on and so forth. I think also, the diversity inclusion program that they just started at our school was a really big thing for me, because there's a lot of us that feel like we've been left out sometimes when it comes to the education, and the education being geared more towards the way other people think than the way we think. I think somebody said we as African Americans think differently. We process information in a different way. And for me, I am one of those people. And then we had COVID on top of all of that, which put us into this virtual thing, which I am not used to at all. I'm used to pencil, paper, write it down, meet my professor face to face. And I don't think anybody stopped and said, hey, like, what do you need? How can we make this a little bit better for you? If that makes sense.
Anybody else want to add to that?
I can jump in and speak only because a lot of this was the brainchild of your work, Dr. Critters. So one thing that MCG has done a really good job of doing is actually listening when our students of color speak. And it's taken some work by, again, my colleagues above me. I think I'm able to reap the benefits now, but they're actually able and willing to listen. So one thing that Bria did in her time was kind of work on this task force reviewing bias in the curriculum. So that was a really, really, really big way for us to have a seat at the table and have an open and honest conversation about the things that we're experiencing as we're going through our curriculum, as we're reading and seeing those things, and what are ways that we can change, if not for what we've experienced, the class behind me. And there's changes that she's done that our class reap benefits for, and things that we're working on my class for the new people. So even if it's bit by bit, only one case here or one thing we're addressing now, we're seeing actual changes and things that we're actually seeing action. So that is something that I think MCG right now is doing a pretty good job of.
I'd also like to piggyback as well. One of the things that our school is doing is, I think some of the people ahead of us allowed us to have this today, but one of the things my school has done is the dean has actually involved us in trying to get more Black and minority faculty at the school. Majority of our faculty is of white descent, and she's specifically involving us in those conversations, involving us in the interviews, involving us in the process of searching for those, asking us, do we like this candidate? Do we like this candidate? What we think about that? And having just, coming just, various times a semester just to speak with us. How are you doing? Those kind of things. And it's really, really made a difference in how we feel about her as, the leader of the school, but also in general, that they're saying they're trying to make change. And just minority students in recruitment, like we see that there aren't many minority physicians or minority students in medical school. In fact, that I'm the only African-American male in my class, and there's not one in the class above me. So when I reached out to the school, hey, is there an African-American medical student I can speak with, a year class ahead of me that can kind of show me the first year how to do those things? There wasn't one for me. And so that's some of the things that the school is, really, really trying to change. And so they've involved us in those decisions. That's been a great help.
That's
really. And to
go.
To piggyback off of that as well, Morehouse is doing the same thing. We actually have a class where we talk about racism, and most, I would say about 60% of our class is African American. And for those that aren't African American, we also want to get their perspective, because we talk about racism, we talk about diversity all the time. We live it every day, but to them, it's something that's completely new. And so the class is called Fundamentals of Medicine, and it actually opens up the space for them to really talk about, you know, whatever biases they may have in like a non-judgmental zone. And in addition to that, Morehouse also includes everyone, like different races on different committees, to talk about how we can include students and their opinions, as well as we actually just got a new dean, and they asked us what we think about it, like who should we vote for? They had a list of different candidates and they actually wanted our input. So it wasn't like they're just making decisions without us. So.
And that's a really good point. And Allison, like Allison was saying, with our executive task force looking at the examination of bias in the curriculum, that includes racial bias, that also includes gender bias, and making sure that we're having those conversations, right? So even though majority of us are Black and brown people on this conversation tonight, having those voices and understanding, you know, what our Hispanic brothers and sisters are going through, understanding those who have maybe come from the Middle East, you know, all the things that are going on there that we may not necessarily be as privy to, having those conversations and knowing what's going on so that we can better support our students. Another thing is too that I will say, looking holistically, like Rick was saying, at who's coming in. So the issue is that, like we've talked about, we're getting Black and brown people into the school. It's very hard to retain Black and brown people at the school. And so being able to be in those conversations, looking, so Kayla, this is definitely for you, looking for those residency programs that have people of color in faculty positions, because that shows you that if gone through the residency program, if somebody has, you know, been chief resident, now they're on faculty, that shows that they're committed to Black and brown people on faculty there. That shows that they're committed to trying to improve the diversity, equity, and inclusion. And so I will brag on my program because that's where I am now. So no shade to MCG, but that's where I am now. And one thing that I really enjoyed during the residency selection process was that UAB had an anti-racism curriculum, not an anti-racism statement. We had an anti-racism curriculum where we were able to have these conversations, things that are going on. My associate program director, Dr. Carla Williams, she came through the program. She was chief resident. Now she's on faculty. Kiki Tider, she came through the program. She was chief resident. Now she's on faculty. So you're being able to see yourself in those positions, right? We're talking about being able to see ourselves in these different positions, but it's very hard to picture that if there's nobody there, right? So definitely making sure that you guys are looking at that. Dr. Price wants to ask, do you ever interface with community physicians that are not faculty? So does anybody actually have an opportunity to talk to any of the other physicians that may be in your different cities around the state that may not necessarily be connected to your medical school?
Well, I have had the privilege of being able to work with Dr. Price, as I've been at home doing virtual learning for this over the last year. He's been gracious enough to allow me to come and shadow and you know, just kind of work with me and allow me to see you know, just see how everything flows and how everything operates. I've also had the pleasure of working with Dr. Myron Rowe. He's taken me under his wing as a mentee. We meet monthly and we just talk about things that, you know, we as medical students, especially as a second year student, you know, things that I need to know and things that I need to look forward, look into going forward. So I've definitely been appreciative of the help that I've received thus far from my older African American mentors.
And we got time for one more person, whoever wants to jump in if you've been able to have a community mentor. That question was asked by Dr. Perry. So please, my apologies, Dr. Perry, before we get ready to wrap the panel up.
Yeah, so
jump in. Okay, Kayla, go ahead.
Go ahead, Kayla.
I was just going to say for us, I feel like not as much as I would like them to. And I say that in the sense of we see them in classes, say if we have them as a guest lecturer for maybe an hour or two, and then those that for example, if a radiologist comes that is a graduate from the school and has that connection with them and works in the community there, and then those that are interested and just see this Black female radiologist, oh my goodness, they have to speak to her, but she's only there for an hour, and the actual interaction time is extremely limited. So I would like to see that more. For my institution, we do have them come in for particular events if we have something, particularly for our Black History Month or any other type of event where we bring in community physicians, but it tends to be more of the same. So it would be very helpful, I think, for many of the students of color at my school to be able to see more faces of those that are in positions that we want to be in. I feel like that is an effort that needs to be increased.
At Morehouse.
Okay, you can be the last person, and then we're gonna wrap it up, okay? Because Dr. Price gave me the cut off.
Yeah, but it's gonna be short and sweet. At Morehouse, for every rotation that we have community physicians. So you're able to connect with them, and they're always so willing to tell you about their experience, tell you about things that you won't learn in medical school, such as billing and all that extra stuff that you really don't get. And it's so great. Like I just had my family medicine rotation this past month, and it was up in Calhoun, Georgia with Dr. Howard. And it was the best rotation that I've had so far. And it's really, really made me consider family medicine. And yeah, I think it's so important because they're in it every day. Yeah.
I'm gonna turn it back over to Dr. Price.
Thank you so much, Dr. Carithers. It's a pleasure calling you Dr. Carithers. But this panel is wonderful. I mean, the future is bright as the participants look at the depth and breadth of the talents, the background, the path that these individuals have taken despite the challenges. I think you can rest assured that GSMA is here for you. There's a wealth of talent within the GSMA, but I think you also heard in some of the earlier presenters, Dr. Tarver, who went to Spelman, who's now at FDA. You have individuals like Dr. Kazmizia Corbett, who's working at NIH, and the list could go on of role models that you can look to. And most of them will be gracious enough to try to counsel and advise and provide you with some of the background. Certainly SNMA has been a strong backbone for guidance, the inner face of all of the different chapters. And speaking out, the reason this panel is here is because you're all outspoken. And so I think we just need to begin to be more collaborative with GSMA and our medical schools now that we have so many. And I'm glad that Dr. Petty had our initial student forum in November, and now we're doing this one, and we just need to expand it. Obviously, a half an hour to 40 minutes is not enough time to go through all of the issues and factors, particularly with COVID, but we will continue to expand that relationship. So I want to personally thank Dr. Carithers and all of the other panelists, Bowens, Hirsch, Johnson, Lewis, Arawodo, Ward, and Dada for your input. And I know there were so many other students at the various schools who wanted to participate, and we will get them in the future meetings. Continue to share with us through your emails, your chats, your Facebook, your Twitters, however you want, TikTok as well. I know Dr. Carithers has a wonderful TikTok on her graduation day that I think you all should look at. But with that, we're going to move on.
Just before you move on, I just
Yes.
wanted to say that one thing that hopefully as we're moving forward in this year, that's one of the things we want to do is to be able to use the GSMA website as a way to kind of connect us all across the state, so that you'll be able to, you know, click on there and find other, you know, other students in either in your city or just across the state that you might say, you know, you may have a question. They can just, you know, say, you know, chime in and answer that question. You're going through this, or, you know, or you're just there, that if somebody else has something that they're going through, and, you know, someone else may be able to fill in. So that is what we're working on now, to use our GSMA website to be able to connect those things, as well as to connect us to you, to be mentors, so that you can continue to reach out, and we can reach out to you in your area as mentors and as physicians and preceptors for you all moving forward. So
Great.
thank you all. This definitely makes me very happy to hear you all and to have this to come together. So thank you. Back to you, Dr. Price.
Thank you. At this point, we're going to move to our next presenter on the program, and that is no other than Adrienne Jones. She's the Chief Admissions Officer at the Philadelphia College of Osteopathic Medicine, and you heard a lot of the dynamic students who we have in the two campuses we have in Georgia, one in Sewanee, and most recently in South Georgia, where I am on the faculty part-time. But I can tell you that as you will hear from Jones in her presentation, we have through our strategic plan and long-range objectives, taken the pipeline, the pathways, the need for support of students, and the diversity inclusion to heart in all of our programs, and we believe we're making some inroads. So with that, Adrienne, take it away.
Thank you, Dr. Price. And let me see if I can work this technology so that I can share my screen.
If you want to share, I'll stop sharing. Go ahead.
Thank you. Let's see if I can pick it up. Let's see here. I think I've got it. Just let me know when you can see it.
We got it.
Okay, excellent. And then let me pull my presentation up. I'm working off of two screens here. Can you still see?
Got it. It's okay.
Excellent. Awesome. So PCOM, a health education fueled by humanity. My focus is to be addressing diversity in medical education and taking you through a look at the 5-year strategic plan at PCOM. First, let me clarify that those lovely students that you heard from, I had nothing to do with their arrival at PCOM. I'm brand new. And I arrived virtually in the world of graduate medical education through working at another school of medicine, a school of health sciences, but have a long history of years in education. And evidently they believed, and so that I could bring something to help with the plan that was actually developed before I arrived. One of the things that had been done that was puzzling, but I asked a lot of questions about during my interview, was a climate study. So evidently somebody knew something was up, and that it was actually time to do something about it. So I interviewed, I think, at least 9 to 10 different times throughout my process, and I kept asking questions about the climate study, and I kept asking questions about the strategic plan. And I would simply say to my new staff at that time, would say, we'd like to accomplish a lot. And I said, well, if it's not in the strategic plan, it is not going to happen. So one of the things I was really excited to see for PCOM was that there were some things in the strategic plan, but initially there were not enough. So the diversity and inclusion and team, which is headed by Dr. Marcine Picaron-Davis, embedded diversity initiatives within the strategic plan, which was great. So if you know anything about admissions, which many of you do, you don't stop recruiting the class because the strategic plan is not set. You keep going. And so we had a hold on the strategic plan launching to inculcate and embed the diversity initiatives, which meant that if we are all called to those same messages, here's the rub. You got to get them done. And so we'll have some actionable items to talk about. So what I did then, once I did receive access to PCOM and the job was given to me, the strategic plan was a part of my 30, 60, 90 discussion with President Jay Felstein. And here's how I propose that we start to make some change. So I want to try to make sure that I watch the time as well. So this is a blank slide. And I debated, besides like putting these wonderful, caricatures of students there, what I wanted to call it. And I was like, truth, speak truth to power. No, so I just left it blank. So I want you to hear what I have to say. The world lurched forward and in seconds became a digital village in turmoil, tussling with the pandemic and racial tension. Front and center, our global public health system became engulfed in a fierce battle with COVID-19. And it had our human race locked in survival mode with our doctors, nurses, healthcare practitioners, and mental health counselors on the front lines. At this point, our own physical proximity to one another still spreads the virus. And many lives, generations, and communities have been disproportionately impacted and some lost. The world has changed right in front of our eyes, and this fast motion playback continues. These healthcare leaders, the ones you're looking at on the screen, will carry a tremendous responsibility at once again. They move to the head of the line to provide solutions. Representation matters, diversity strengthens outcomes, and PCOM is in the room where it happens with a seat at the table. Diversity is our engine to move racial justice, social justice forward and to carve out a pathway to greater excellence. And so I took the words of the mission statement and really pushed them back at the executive team. And every time we talk about what we're trying to do, it comes up in the messaging that I'm using in my ideas about how we're going to diversify the strategic plan to diversify the student body and also open up more capacity to really talk honestly about what's going on. And literally, if we can't talk honestly at the beginning, as you've heard the students, their struggles through their programs, you can't talk honestly at the end. So it's really where we start together, figuring out how we're going to do it. So the PCOM mission, it already speaks to educating healthcare professionals to care for the whole person and advance the health of diverse communities. And I also kept pointing out that it was about us, but it was not so much about us that the focus isn't on us, but where are the people that are not in these diverse communities learning how to deal with us, right? So it's very important that the mission statement, you focus on it because you're talking about the whole person, which really deals with osteopathic medicine. It has to give students an opportunity to not only learn how to work in these diverse communities, but if they're in a diverse community, they have to learn how to work together. And they do that before they get out into the diverse community. And so students having experiences in the classroom that don't reflect that, there's something we have to do, and we have to start opening up that conversation. So one of the ways a call to action was to develop a coalition of support. And there are more offices reflected here, but I wanted to talk to you about some of them. One in particular was institutional research. I love working with Dr. Michael Roberts, who works in our institutional research department, because we do crazy things together and we think out of context of just pie charts and digital things. And I'll tell you, I'll show you on some of the things that we're working on. The Office of Marketing, I have now an admissions communications vertical, which is exciting, under the admissions hat. And so we're doing a lot with our nurturing campaigns. At the Office of Diversity and Community Relations, we are tied very closely together because of the DEI initiatives, along with financial aid and the registrar, and many, many more who will aid in this impact on recruitment. So I am actually building a team. And they think we just work together because it's what we do, but I'm building a team, and this is very important for the strategic plan. So here are the resources. Well, let's take a look at this little fellow right here. You see him? We have to grow him. So we're not just going to find students on the side of the road, and you don't wait until the pipeline becomes dry. So you have to start somewhere. And we heard the talk about elementary students, and I've been working with the middle school program, PMSCP we have at PCOM, and those little 6th, 7th, and 8th graders will make you sit down because you're like, gosh, what? They know so many things already. Imagine them as little, I would call them little instigators about the virus and talking about the vaccine. They were very intelligent to carry this back to our community. So it was exciting to watch them grow. But we really hadn't done much with this particular group. And I'll tell you a little bit more, but I'm going to keep moving. So pathway programs mentored by our own PCOM students are the way, because I was impressed with our SMA group and many of the other student groups who were mentors as part of these programs. They were just so gentle with the students, you know, and they were also, so we have a high school program called HPrep. And they were gentle with the high school students and really honest about their struggle. So they weren't acting like they were just perfect and everything worked out. And here I'm in medical school and now I'm an expert. They just really, they broke it down and they came to where they were. And the students love also talking to some of the doctors in our programs that come through, because for many of them, they've never seen anyone in their community. So you're starting to hear some things that were from our prior conversations that have come up. Affiliation agreements is another way that we plan to grow a diverse student body at PCOM. And we're going to be using, specifically when we're talking about medicine and the DO profession, we're talking about HBCUs, HSIs, and MSIs, and also using biomed as a way to anchor students coming in. And this is really exciting, although it feels a little overwhelming. Just today, I received word from the president that the affiliation agreements and the articulation agreements will now be hosted in my office, which gives us incredible leverage to go out and articulate exactly what we need. And then we also went to legal to build them. So we can look at language, we can look at the metrics and really move those as we need to. And then finally, the current applications for sure, you know, you're limited, as the students have talked about, with current applications, because if they don't apply through the ACOM or AAMC, they're not coming. They're not going to come if they don't apply. So you need other areas where you can drive applications. We need to also reflect again that a big portion of our conversation has to be about the lack of Black men in medicine. And of course, as I heard the students talk about Hispanic students as well, this also was a concern for PCOM. So all things converge. And so the guiding principles, it became obvious that we just could not get away with doing what we said we were going to do. So if you have a mission and you say it, you got to be about it. So the strategic plan, the pathway to greater excellence, has now included the diversity and inclusion DEI strategic plan. So those two things have been merged. And lo and behold, just after we had the breakout, as we talk about COVID-19, then came the Black Lives Matter movement, and the students talked to us about what was going on, and they commissioned the President's Commission on Racial Justice. And so now that also impacts us as well. So those areas are actually included in the strategic plan. And my own 2021 admissions URM recruitment plan includes all of these items. So we're touching it on every level within the strategic plan, which also touches curriculum, faculty hiring, student affairs, alumni. It's all nested in there. And this actually, all this information is available on the pcom.edu website. So you can actually see what we're talking about. So one of the things that needed to happen was to really take and analyze the recruitment data. So I'm still launching one of the major things that I had to do for PCOM is to launch a huge initiative for CRM. And we needed a new CRM, and we are implementing Slate. We're about 50% through the project. And we needed an opportunity to really build dashboards and reporting to examine the trends of URM candidates. We could not really see what we needed to see, like where are they dropping off? So comparing the work that's being done in the retention area with student affairs and with institutional research, and you overlay that, that gives you more information. And also that recruitment is retention, so that you're picking up students at the same time with the intent to actually watch them move through the process. We are examining as well, and the president gave me the green light to try some projects where you're not just focused on MCAT. So we joined a pilot that's going on in ACOM that's called HARP. It's the Holistic Admissions Recruitment Process, which uses artificial intelligence to enhance admissions decisions and pick more diverse candidates. And you actually can quantify bias and take it out. And you can actually choose students, more diverse candidates. And guess what? It's using natural language and not scores. We actually launched a pilot in each of the different locations for PCOM, South Georgia, Philadelphia, and Georgia, and it was interesting. So we're now starting to analyze parts of that, because I know a lot of my colleagues said, be careful about bias that's indicated in AI, but it's been very interesting to see these results. So I'm showing you some charts, and this is some of the work that Michael Roberts and I are doing, because we found that our Hispanic numbers were really low. So let's just take a look at Philadelphia. This is like total student numbers, and we had about a little less than 2% of students Hispanic. And we were pulling a couple of categories, as our first speaker, was it Dr. Tarver? Dr. Tarver was talking about making sure to look at everything, race, ethnicity, and she talked about ancestry, but we had only been pulling categories of race, ethnicity, and multi-ethnic. And something was not right with the Hispanic numbers. And so we went back in there and said, there's got to be more data, because we can't see who's Hispanic and who's Latino. And we found also another premise. So within the chart that you're looking at, the first one talks about Philadelphia, you'll see the Hispanic numbers at 1.9%, 1.95. And what we thought we might do was to, as we're pulling this data as an example, is we found that there was a field that hadn't been pulled and had not been utilized, called new ethnicity. And within the new ethnicity is where you would see Hispanic and Latino. So the student self-identifies. And that, and you've heard Dr. Tarver say it, but I would also repeat it, that it's a social construct. And so if a student doesn't identify, then we don't know. But if they do identify, why are we not using that category? So the second smaller pie chart is a representation of another 8.8% students who identify as Hispanic or Latino, but yet who also may identify in the multi-race category. So the next level of work, if you looked at my chart again for the next time, is to get into the multi-race category and decide what we're going to do with it. It is very rich. It is full, and it exposes a lot, and it gives us a chance to kind of look at things. So the next category, or the next area, was the Georgia campus, same thing. As the Hispanic population started to come to life, another 7.9% here, and another 2.1% here. And finally in South Georgia, again, really strong numbers started to appear. And so this is just part of some of the things that we can do with Michael and his data to help us get a better sense of just what's going on. Because one of the call outs from the racial justice group, overlaid with the diversity initiatives, as well as the strategic plan, is to do a holistic review of admissions. And another piece of that is to really determine what is the URM, and to begin to look for a more contemporary definition that allows us to be more inclusive. Finally, the review and revise the admissions process probably has been the most creative way to, I would say, push the definition for URM, but also to utilize a holistic process that minimizes bias, focuses on non-cognitive skills, and it looks at the applicant's journey alongside metrics. So with that said, we've added in some gender awareness within the questions that come through many of the applications, as well as who are the student mentors, who's the student mentors, by looking at their background even more and really digging into their, the AI really digs into their answers to the questions around their experiences, their essays. It's amazing how this algorithm is reviewing the natural language. And then we created a pathway prioritization team for the one PCOM concept, which is looking at life across 3 campuses. So 1 university in 3 different locations, and a pathway prioritization team that acts as a resource for diversity for the entire admissions team across all 3 campuses. And we work with the library, work with DEI, we do quite a few different things. And finally, the other piece of this is that we're going to increase outreach. It begins by looking at the one statement, which I still don't even understand what it means, to increase admissions of Black and other URM students. It just says do it, but it doesn't offer you a lot of alternatives. So we're going to figure out what those are. So as I mentioned to you, the strategic plan has an overlay as well that asks for expanded pathway programs. And we're going to do that through the articulation and affiliation agreements with our HBCUs, HSIs and MSIs, and we're slotted to have 2 for year 5, and we've completed the first 2 and are on our way to many more now. The pathway programs give us a way to cultivate interest, readiness, and mentoring. And finally, the current application pool is a place where using the AI, we can actually pull students that we might have missed in the past. Looking at all of these things allows us to really talk about the outreach. And then also, yes, we saw an increase in applications like many of the medical schools, but you still cannot touch all of those students. And the AI gives you an opportunity to see if there's something that you're missing and also to challenge your process. The last thing was to establish best practices. And one of the things that the students asked for, and we are doing, is to provide a space for the affinity groups to speak with the applicants. And this is a really important aspect of it, because you want to think about the whole entire campus is rising up to help you support and recruit students, and that the students who are already there are a very important message, a part of the messaging that current students will be looking to help and understand. So you should purposely put them in the way of students who are trying to prepare, so that you, as you think about the concerns that students mentioned in the last presentation, that some of those things are taken care of. So our admissions ambassadors, our Student National Medical Association, and current students are very involved in our process right now. In fact, they're launching the first ever event with Georgia and South Georgia as a pilot with our class, and it's called the Collective Connection. And basically, it's all student run. They created the sessions, and they're going to be meeting all URM students across all programs. We even included the Asian students. We didn't leave them out because they're not considered the minority, but they're all in there. And the things they came up with were awesome. So I'm just going to be a fly on the wall and just observe it and hope that we have a lot to learn from them. Finally, the other charge, I don't know how admissions always gets in the money, but we did. It was to offer more minority-based scholarships, not in lieu of financial need-based scholarships. I want to finish by pointing out the importance of the money, because not only does it change lives, but it was different perspectives. And also, when the money is awarded is also equally as critical. So we've been able to have some of those conversations, but specifically for this last pilot, we received money to diversify the physician assistant studies program. And there was a belief that if we offered more students of color in the PA program a place in the class, that we would have to raise the amount of efforts around academics. And I just blew that out of the water. I said, this is not true. So instead of just showing you how many students didn't take our offer, what I showed as a pilot was the number of students of color that we had admitted from all different kinds of schools, and said, why don't you take a look at these students instead of what comes at the very end after you have no money to offer. And then what we showed was that the students who had been admitted versus majority students were equally, or if more qualified, and that if we placed additional funds in support of their offer of admission, that they would come, and they did. So over using 3 years of data, 2021 has been the most impactful. Now, the reason why we isolated the physician assistant program for this particular pilot was because there's not one professor of color, not one, none, zero. The only people of color are my admission staff. So it's important to have a diverse admission staff too, if you can talk about these different issues. And so they've been charged, initially, there was kind of like silence around diversity. And that now the PA physician assistants PA has taken on this incentive as a profession. And they had to write a diversity, they had to do a diversity study and build a diversity committee. So more things are coming as a result of it. So the scholarships were one way in which we can influence the development of students. But again, it's only the beginning, it's the first resource. So as I close out, I would say that all of these things as part of the strategic plan being laid out the way it has been has allowed me to be a little bit more creative, and there's more to come, and I'm still learning. But I also think that as a result of trying to present this one creative pilot with the funding, I was given another $500,000. And so we're going to get to apply that to all the programs, including DO, to see if there's a way to offer some support with some of the resources. We're also in conversations of trying to negotiate with some of the prep study places, looking for ways to help students remove barriers and work through many of these issues. Most importantly, I would say that the strategic plan, it doesn't force the university to do the right thing. It allows a pathway to be established, and we all agree these are the areas of importance, and we focus our attention on them. And by including all of the layers that are part of admissions, the strategic plan, the diversity, there's just no way that I could miss to be able to deliver in these areas. And that's also impactful as well, because slowly but surely it will move over to other things, and it has. So with that said, I would mention that I've been pulled into conversations around matriculation. I have been a very big fan of the Learning Resource Center, not so much for the academic piece of it, and also not for mental health, but for the opportunity to provide an advisor to students, as you heard some of them talk about some of their issues. So I think that, as I continue to carve my way through the strategic plan, I'll be able to offer more insight as to how things are impactful, and be able to to be able to influence some of those conversations around resources that students need in order to be successful their entire time in medical school, and not just from the beginning. Thank you for your time and attention.
Thank you so much, Adrian. That was an excellent presentation. I'm not sure if we were able to monitor any of the questions. We probably can handle one or two questions in the chat before we move on to the next segment. But I think those individuals participating in this meeting can clearly see that Adrian is not one to be held captive. She demands accountability. She is a force around the table. And so the metrics are there for the university to show that they're following the strategic plan, not just on paper, but some real outcomes. And so I'm proud of all the work that I've seen her do. I think she doesn't want to take credit for the students that are here, but they must have known you were coming, so they had to clear house correctly. And lastly, Jay Feldstein, I just want to let people on the call who are not familiar with PCOM, when you have that kind of commitment from the top in terms of putting the money on the table, to structuring the long-range plan, and to hold the individuals accountable to make it happen, it becomes a lot easier. And so with the very vocal student body that we have in the SMA chapter feeding into leadership, I believe there are going to be very phenomenal things coming out of PCOM over the next few years.
Kayla's asking me a question, Dr. Price.
Yes.
She asked, how do you plan to make sure the level of access is equal across all of the campuses?
Okay.
And well, one of the things that I think that's really important is that prior to my arrival, what I learned immediately was that the three offices of admission and the program directors didn't, at all three different campuses for all those programs, and while we're talking specifically about medicine for DO, really didn't communicate. And that's also changing. So one of the things that you'll be interested to know is that the DO admissions committee, the FCA, the Faculty Commission on Admission, has included for the summer. They usually look at several different projects, and they chose Black men in white coats as their focus for the summer, to figure out across all three campuses, what more could we do? But we'll also be touching base on raising awareness about what's going on. So Kayla, to answer your question, One of them is to begin for me to unpack and open questions that we haven't been able to ask before, and to make sure that everybody's aligned. So my whole team saw the Black Men in White coats, and we're offering that as one of the other areas where we can begin to talk about some of these issues. And then we're also kind of ganging up. You know, I met Dr. Price, and so we are working together. There are faculty, about 9 or 10 faculty across all 3 campuses, and we're working together. Admissions is joining forces with DEI. And again, I've been able to kind of finagle my way onto several committees. And that way you're able to kind of ask the question. And again, if it's not, if it's a part of the strategic plan, we have to do it. If we're not doing it, it shouldn't be in there. So I'll continue to keep talking to you and answering questions. So for those students that are from PCOM, I'll be in Georgia, Suwannee and Moultrie in July. And I would definitely be happy to meet with you and just continue our conversations. And for those students who are not from PCOM, I mean, I just kept trying to take a picture of all of you on the screen because that's just a beautiful thing. So good luck to you and congratulations.
Great. Thank you so much.
You're welcome.
We'll go ahead and move the agenda, and we certainly will welcome you back at one of our subsequent meetings to elucidate on some of the subsequent questions that came in asking, what does success look like in terms of metrics, and what do we feel that we're going to be able to do in terms of the mass appeal to African Americans. So I'm going to invite you back on behalf of the president of GSMA and the NMA to continue to share our successes at PCOM. Great. All right, we're going to move on in our program to the next segment. And this is part of the program that our distinguished president will be talking about a number of issues related to her awards. But I wanted to leave you with a quote from Michelle. There are still many causes worth sacrificing for, so much history yet to be made. And so we're going to continue to move down that path. So our awards program is a banner part of our annual meeting, and that's going to be led by our president, Dr. Erica Russell Petty. So Dr. Petty, you want to take on?
Yes, good evening again. Thank you, Dr. Tarver, Dr. Wimberly, and Dr. Jones for your presentations. And I again thank all of our students for your participation, and hopefully over the course of the years, we will continue to move forward and make things better. I first wanted to have Dr. Mance, if he is still available. He wasn't able to be on the phone on the call earlier, and that, as you may know, we are able to have the Tennessee Association, which is the State Volunteer Medical Association of Tennessee, who is joining us in our convention today and tomorrow. And I wanted to give Dr. Mance a couple minutes to be able to give greetings if he's available now.
Oh yeah. Hello everyone. I'm in Nashville. You might can hear me someplace. Well, I'd like to thank everyone and congratulate everyone for having such a great conference. The information that we're receiving is timely, that give us insight and wisdom, respect to things we need to do and to improve our society so we can be able to respond to the changing world. And the COVID has brought about a great change in our lives, but we need to make sure that we continue to be learning and growing, and thank all the presenters. And we'll have a great presentation tomorrow.
Yes, thank you very much, Dr. Mance, and we look forward to the scientific program tomorrow and having you there as well. and all, and all of our Tennessee physicians. So at this time, as you know, we were not able to have our conference last year, and we wanted to still give an opportunity for our then president, Dr. Wilkes, who is now our chairman, to be able to present the presidential accommodations that he had for our doctors for the 2020 year. So at this time, Dr. Price is going to show those videos, and we will give each of the awardees, if you want to take a moment to, a minute to have something to say, you may. And I do know that one of the awardees isn't present on the call, but so we'll at least just give a minute, and then if they want to speak, they can.
Okay.
Hello, I'm Dr. Shelby Wilkes. I'm here to present 3 candidates who were given citation during the tenure of my presidency of the Georgia State Medical Association. The first candidate I'd like to highlight graduated from the Weill Cornell Medical School. He's a board-certified pediatrician. He was the 105th president of the National Medical Association. He's been involved in collaboration to reduce healthcare disparities and to increase healthcare equities. He's an associate professor of pediatrics at the Philadelphia College of Osteopathic Medicine. Let us congratulate Dr. Winston Price.
Thank you so much. It's an honor to be recognized by your peers. It's also a deep honor when you're responsible for the IT component of a meeting and embedding videos, but not know the content of the video. I'm especially proud of the work that the Wilkes brothers have done with GSMA, and I'm intrigued with all of the opportunities that GSMA has brought to the table on behalf of Georgia. And as you know, we've launched our new website. We are the voice of healthcare and equity for Georgia. And I'm thrilled to be a part of this wonderful organization. So thank you for the distinguished honor of the award.
Hello, I'm Dr. Shelby Wilkes. I'm here to present.
We'll move on to the next award.
Recipient of the Presidential Citation is a graduate of the Boston University School of Medicine. He's a hematologist oncologist by specialty training. He's the founding president and dean of the Morehouse School of Medicine. He is the former U.S. Secretary of Health and Human Services. During his tenure, one of the major initiatives which he started was the Healthy People 2000 and the Minority Medical Center, which is now an institute of the National Institute of Health. Let us welcome Dr. Lewis W. Sullivan.
And thank you, Dr. Sullivan. I know is not able to be on the call tonight, but we will make sure that Dr. Sullivan gets his award.
He'll be another president. Next candidate for the presidential citation during the tenure of my presidency of the Georgia State Medical Association, graduated from the Morehouse School of Medicine, performed her residency at the Allegheny Hospital. She formed the Radiant Women's Health Group in Conyers, Georgia. She's board certified in obstetrics and gynecology. She's been extremely active in the local organization, including the Atlanta Medical Association, and the Georgia State Medical Association, the organization of which you will eventually become president. She's also done a leadership forum with the Medical Association of Georgia. Let us welcome Dr. Julianne Burke.
Dr. Burke, are you on the call?
I am, and this is really a surprise. Like, what? Thank you. I feel like I'm running up to the Grammys. Thank you, everyone. I appreciate that, Dr. Wilkes, and my family here at GSMA. Look forward to many, many more years of work with this fine organization. I'm in the mountains and my connection has been bad, but thank you so much, and I look forward to tomorrow. Thank you.
Very good.
Thank you, Dr. Wilkes.
Candidate.
Turn it back over to you, Dr. Petty.
Yes, so the next award will be presented by Dr. Paul Douglas. This is our Community Service Award.
Good evening, everyone. And it's certainly been an eventful meeting so far, and I really appreciate everyone being here. And I bring you greetings from Hilton Head. I came to Hilton Head hoping that someone would be here to share this beautiful weather with us, but it is good to see so many of you, at least virtually. I have the honor of presenting the George A. Johnston Senior Community Service Award. As many of you may know, George Johnston Senior was a stalwart in the support of Georgia State Medical Association, and he certainly was part of the medical community and structure in Macon, Georgia. He produced two wonderful physician sons, Benjamin and George Jr., who have also served admirably in the Macon area. And so it is certainly, I think, fitting that we recognize someone who has been equally as supportive to their medical community and deserving of this award. This year's awardee is Dr. Reginald Fowler, MD, who is a board-certified internist and a native of Rhode Island, who received an undergraduate degree from Brown University in Providence, Rhode Island. He received his Doctor of Medicine degree from Tufts University School of Medicine in Boston. He then completed his internship and residency training in medicine at Grady Memorial Hospital and Emory University School of Medicine affiliated hospitals. He is a founding medical director at PruCare, an HMO in Atlanta. He was the first African-American medical director at IBM in Atlanta. He served as president of Paces Ferry Medical Group in Atlanta for 23 years. He was also the first African-American in the country to be selected to MD VIP, which is a group of physicians who concentrate on the prevention of disease. He served on the medical advisory board of this organization for almost 10 years. He has been selected as Doctor of the Year by the Atlanta Black Clergy and was selected as one of Atlanta's top 25 African-American physicians by Black Health magazine, as well as receiving many other awards. In addition, he has a 5-star rating by HealthGrades. He has volunteered multiple times over the years to perform examinations on athletes in Atlanta and Metro Atlanta school systems free of charge. He has been an assistant clinical professor for Morehouse School of Medicine and a preceptor for medical students in Georgia, and also physician's assistants program in Georgia, as well as programs around the country. His proudest accomplishment is his marriage to his lovely wife, Donna, and the birth of wonderful and successful children, Brandy, Stephen, and Casey, all of whom graduated from public school in DeKalb County. On a personal note, I want to say and share with you the fact that whenever there is a question about medicine in Atlanta and our region, Dr. Fowler is quickly sought out. You have seen him in the newspaper. He is truly a thought leader in the medical community and certainly very deserving of this acknowledgement and award. I am very proud to present to you this year's Community Service Awardee, Dr. Reginald Fowler. Reggie, congratulations.
Well, thank you very much. I guess, can you hear me? Can you hear me? Can you hear me? How about now?
That's better.
Yes, we can hear you. Okay, you can hear me?
Yes.
Okay, fantastic. Well, listen, first of all, I'd like to thank everyone for this just unbelievable award, which I did not expect. All I've tried to do is what God put me here to do. And I want the students to know, because I'm very student oriented. And I've been teaching for a long time, medical students, nurse practitioners, physician's assistants, you name it. And it's been a fantastic experience. I'm so proud of the students that were on the call tonight. And I encourage them to keep going, and don't let anyone tell you that you can't do anything in this business of medicine, because whatever you apply your mind to, you can do it. So I encourage you guys to continue on the path. We need more thinking along what's happening with the essence of what's causing disease. This is what I've always tried to concentrate on. We all learn in medical school and our various schools how to treat disease, but what is actually the essence and the foundation of what's really causing these diseases? And so be innovative in your thinking so that you can not only help your patients, but also help your colleagues in the medical community. So again, I just want to thank everybody for this prestigious award. Even though I kind of dropped the stethoscope on May 1st and am not actively seeing patients anymore, I'm still continuing on the path of trying to do whatever I can do to improve the healthcare of people around the country. So thanks again, and love you guys. Have a great night, and go Hawks.
Wow, thank you so much, Dr. Fowler. Congratulations. So now we are going to have my presidential commendations for this year. And my first award goes to Dr. Warren Hutchins. Dr. Hutchins, during several conferences in Hilton Head, knowing that I was the then president of our local society here at South Atlantic Medical Association, he would take me and encourage me and to continue working in our community so that I could continue helping those here. And little did I know, he was also grooming me to become the president eventually for the Georgia State Medical Association. When situations came up in our local society, within our local societies, with the local minority doctors, he's always been willing to help me and to help me find someone if he did not know the answer. He has worked with me throughout the years to prepare for leadership roles and, as I said, to eventually become the president of the Georgia State Medical Association. So I wanted to recognize Dr. Warren Hutchins. Are you still on, Dr. Hutchins?
Yes, I'm here. I'm all over the place. And I want to thank you for taking that to heart and being encouraged by your efforts and your energy and the things that you have done over the past year during the COVID-19 pandemic to keep Georgia State Medical Association alive. I also want to thank the organization for the condolences for the loss of my oldest brother, Billy, Dr. William Hutchins. But again, I really appreciate the fact that you and some of the students, one of the students from Mercer is also on. And, you know, these are things that really keep me going. And I really appreciate what Georgia State has done to keep our younger generation here. And hopefully they will join the organization and become leaders just like you.
Thank you so much. Thank you, Dr. Hutchins. My next award goes to Dr. Millard Collier. Dr. Collier just always has the right things to say at the right time. At the time when I first started coming to GSMA, he became president of GSMA. And when I asked him if the state president would come to Savannah, which at the time the conference is in Hilton Head, so not far to come, but he still had to stay over in order to be part of our banquet that we were having, our awards program we were having. And of course he said, as he always does, of course he would participate. And as I've known Dr. Collier through the years, he has continued to be that same person who is willing to fill in wherever possibly needed, always encouraging everyone to have a good time and to continue to move forward. So at this time, I wanted to recognize Dr. Collier.
Thank you so much for this totally and completely unexpected award. I greatly appreciate and love the Georgia State Medical Association, and your leadership has been amazing as I have watched and observed you grow from the meetings at Hilton Head, where you were quiet and shy and started off doing the prayers for the dinners, and now look at you in an executive position of leadership. And it just goes to show that each one teach one, and that if we nurture leadership, that it will happen and turn into greatness. And we're just so glad for all the things that you have done, particularly in this very challenging environment that we have all had to deal with this coronavirus. So thank you. And we look forward to next year's meeting face to face amongst all of our participants. I'm so glad to see we have so many people on the call this evening. So thanks again. I greatly appreciate being honored in this way. It's always great to be recognized by your peers. Thank you. Thank you. Thank you.
Thank you, Dr. Collier. Okay, and my third person I want to recognize is Dr. Adrian Atkinson-Sneed. While I was still president-elect, Dr. Atkinson-Sneed began asking me to let her know if there was anything that she could do to help. Throughout this year, she has called me and encouraged me. She's volunteered and provided whatever information she thought might be helpful to further our endeavors with GSMA. And so I just wanted to recognize Dr. Atkinson-Sneed, if I can say your name out, for your encouragement.
Thank you. I am also very surprised. I was not expecting that, but I appreciate your support. And I'm always here to continue to support you and support the GSMA. It's been a wonderful year. And I think that our organization has persevered. We've shown our strength as an organization to not only get through this, but to thrive in this condition. And I'm happy to serve, and thank you again.
Thank you. Thank you. Okay, so the last one that I wanted to do is we know that this year has been tough for everyone. I wanted to, just as I said, having this student panel has meant so much to me. We did the one back in the fall of the past year, and then this, and of course, I'm a pediatrician, and so, you know, mentoring our children and helping those that are coming after us is definitely dear to my heart. So we wanted to thank all of our students who have participated. And this year, what we wanted to do was to recognize the presidents from each of the SNMA chapters. We are going to give each of the presidents a $500 scholarship from the Georgia State Medical Association. And I know there's some presidents that are on, some that are not, so I'm not going to ask them to say anything, but I just wanted to say that we are recognizing them and we are going to be giving them those scholarships. We have 8 chapters here in the state of Georgia for our 5 schools. The 5 schools are, of course, MCG, Medical College of Georgia in Augusta, Morehouse School of Medicine, Mercer University College of Medicine, and PCOM, Philadelphia College of Medicine, and Emory University. And what happens is that if a school has a campus, a different campus, then they have to have a different chartered SNMA. So even though we only have 5 schools, we definitely have we have at least 8 chapters, and I believe we have a 9th one that has been chartered as well. So so those are my recommendations, my accommodations for this evening. And so now we're going to have Dr. Paul Douglas, who is going to come back, and he is going to recognize our 2021 Distinguished Service Medallion awardee.
Thank you, Dr. Russell Petty. I have the honor of presenting the Service Medallion tonight. As you know, this is the Georgia State Medical Association's award for an individual who has demonstrated and distinguished themselves in overwhelming support of Georgia State Medical Association, as well as the National Medical Association. This year's awardee is Dr. Winston Price.
What?
Dr. Price is a board certified pediatrician, and I hope we don't lose the connection. Don't fall out of your chair, Winston. Dr. Price is a board certified pediatrician and served as 5th president of the National Medical Association. He serves as the president and chair for the National African American Drug Policy Coalition, and also serves as the chair of the Southwest Georgia Area Health Education Center, which focuses its mission to recruit, train, and retain a robust and highly qualified health workforce for 38 counties in Southwest Georgia. He also serves as Chief Information Officer for the W. Montague COBB-NMAHI Health Institute. The Institute is a health equity think tank and focuses on increasing the pipeline of researchers from currently underrepresented minorities and works on joint initiatives with the NIH All of Us research program. He to serve on the Medical Society Consortium on Climate and Health Council Steering Committee. He has served on numerous advisory boards, including the Board of Directors of the National Center on Missing and Exploited Children, the Childhood Influenza Immunization Coalition, the Adult Vaccine Advisory Group, the Merck Vaccine Division, and MediImmune RSV Advisory Group. He was recently appointed to serve on the Medical Society Consortium on Climate and Health Steering Committee and continues to represent the NMA on the National Adult and Influenza Immunization Summit. Academic positions at the Philadelphia College of Osteopathic Medicine as an associate professor in the Department of Pediatrics and director of pathway programs for the Southwest Georgia campus and assistant professor of Pediatrical College of Georgia. Dr. Price also practices clinical medicine, serving a Southwest Georgia population with a focus on preventive care. As you, Dr. Price is extremely busy. His commitment to Georgia State and his commitment to the National Medical Association goes unquestioned. Everywhere that Winston has been, he has provided leadership. He has helped us weather the storm. This year, as we dealt with the COVID-19 pandemic, Winston has been one person that you can always count on to get the job done. And so I think that we are all blessed in Georgia to have him a member of our medical community, and certainly he is deserving of this recognition based on all of the commitment over the years that he has provided for not only Georgia State, but as well as the National Medical Association. So it is an honor for me to present this year's Service Medallion awardee, Winston Price. Congratulations, Winston.
Thank you so much, Dr. Douglas. This is truly an unexpected surprise. I thought I was on the planning committee to help with all these selections, but you all are good at keeping things under wraps. Let me say that, you know, the expression to whom much is given, much is expected. And what I am simply trying to do, as I think many of the students on our panel talked about, was the ability to give back. And so I know in receiving accolades and awards that it was not something that I did by myself. Each and every one of you in some shape, form, or manner moved my feet, held my hand, lifted my head, shone the light, and allowed me to continue on an unencumbered path and to meet the challenges. And so each and every one of the individuals on the call are part of the fabric that allows anyone to receive this prestigious honor from GSMA. And I'm ever indebted to the organization and will only do, as a result of this, more to be deserving of this award. So thank you so much. And thank you to everyone who has made this possible.
Thank you, and congratulations, Dr. Price. Yes, you have been, I can't even begin to explain how helpful you have been throughout the year with everything that I have asked of you. So I thank you so much.
Well, you got a senator elected, so I was more than glad to help.
Yes, we've done some things throughout the year. So the only other thing that I would like to say for tonight, other than just thank you all so much for being on the call, I'm actually going to have, and now I would like to say thank you first to Kimberly, who is the other person who has helped throughout the year, Dr. Kimberly Williams, who is, just always doing all of the lead work, all of the computer work to help us to get, the program together, to keep everybody on task and on track. So I definitely thank you, Kimberly, Dr. Kimberly Williams, for everything that you have been doing throughout the year. And of course, we'll continue to bug you throughout the year. So, but Kimberly, if you would give the instructions for the CME.
Okay, everybody, thank you so much. We appreciate everybody participating. Dr. Price is going to put on screen a QR code, which means you would need to take out your phone and take a picture of what's on the screen. That's the QR code. Or click on the link. There's a link there, https CME tracker. You need to write that down, click that link tonight, or like I said, take a picture of the QR code and use code 11901 to complete today's CME evaluation. And you must do that today so that you can receive your credit for today's session. There's 2 CME credits for today's session. So again, either take a picture of the QR code on the screen or use that link and go there using code 11901. This will only be available for you to get completed. I think it's through Monday. So you have a couple days to get it complete. But after that, it will be gone and you can't access it. After Monday, you can't access it next year. So thank you so much. And we look forward to seeing you all tomorrow.
Yes, again, thank you all for being with us through the night, and please log on. You can log on probably by about 7:50 in the morning. That way we can make sure everybody is able to access the Zoom, and we'll be prepared for all of our scientific meeting for tomorrow. Thanks again, everybody, and good night.